Yes, ma'am. We can see your presentation.
So everyone, a very good evening to all of you, and dear students, welcome. And thank you, Dr. Nausheen and Dr. Bushra, for your kind words. And of course, a big thanks to Dr. Sumit for conducting this excellent online teaching program. Uh, I have two things to say in the very beginning. First is that I will be missing Dr. Anita Borges, madam, because she was the backbone behind this whole teaching program, the brainchild, and her efforts were commendable in bringing this series into existence. And then Dr. Sumit is doing a great job by continuing the whole teaching program the way it was going on for the last so many years in her presence. So madam was a great teacher and I dedicate this whole teaching session to her. And secondly, I want to just share my feelings that today is 14th of May. And you know, dear students and all present here, I've been teaching pap smear for such a long duration and I have a very sincere passion for this subject. So, and I always had the idea that I should be taking a teaching program on 13th of May every year. And why? Can somebody tell me why? Can I see the faces of how to? Hello?
Yes, ma'am.
Hello?
I think you are on
Yes,
full
ma'am.
screen, so it won't be possible for you to see the
So how do we
students.
reduce it? Each time I have to stop it.
Ruchi, can you help with that? I'm
No,
not sure.
I think not possible. If you have a full screener, you can't see anyone, ma'am.
Okay.
You just
Okay.
only hear. Yeah.
Okay. So I'll just complete my expression. So I always had a dream that I would take a teaching session every year or some activity in Gynaec Cytology on 13th of May, simply because it is the birthday of Dr. George Nicholas Papanicolaou, after whom this pap smear has been named. So I'm so fortunate that, but it never materialized so, but I'm so fortunate that today, 14th of May, the nearest day to the 13th, almost we should say, that I'm doing this teaching program. So I'm really grateful to the Almighty that He gave me this opportunity, and to all of you who chose this date, although unknowingly, but it happened so for me. So I'm really very glad. Now, if we have to just move to case number one, I think the case number one has been given to Rachna.
Yes, ma'am.
So any talk on Gynaec Cytology, I believe, is incomplete without paying a tribute to Dr. George Nicholas Papanicolaou, whom I told you that he was born on 13th of May in 1983 and he died at the age of 78 years. The woman whom you are seeing in the second stamp is his wife, Andromache Mavrogeni, who assisted him throughout his research work. I have few disclaimers over here that cytology, biopsy and colposcopic pictures that I will be showing you, and I have sent the cases. They are from my own material, from the screening camps that I conduct, and the slides and patients during my consultation in my laboratory and otherwise during the medical college years. And all the source of this material is the Bethesda System by Ritu Nair, Wilbur and David, the 2015 year the book was released, and my own book on uterine cervix cancer and the Bethesda System, released in 2022 and licensed in the US. Coming to case one. Yes, Rachna, please tell me.
Ma'am, case one, the history was 53-year-old woman complaining of irregular menstrual cycle. Pap smear was conventional pap smear, specimen adequacy. It was adequate for evaluation. Since end cluster of endocervical cells were also seen, as well as dysplastic cells were also seen. It was negative for intraepithelial lesion or malignancy. There was mixed population of intermediate as well as some parabasal
Now,
cells.
you can tell me exactly what you are seeing. Of course, that was very nice of you that you framed the report at the very beginning. That's a very classical thing that should be done. But now we'll be stressing more on morphology and we'll try to avoid all other discussions. So if we have to focus on morphology, what you are seeing in this particular picture or
Mostly
the slide?
intermediate cells are seen in this smear. Mixed
All of them
population.
are intermediate?
Ma'am, some of them are dysplastic cells are also seen, and
Which, I mean, you are seeing how many dysplastic cells in this, you said? And are they really dysplastic? Because you have reported, as you dictated your, narrated your report as NILM. So that means there is no intraepithelial lesion or malignancy.
ma'am, sorry, metaplastic cells, not dysplastic cell, metaplastic cells.
Okay, so you wanted to say metaplastic.
Metaplastic cells, intermediate cells, and metaplastic cells.
Okay, now can you tell me the classical description of both these cells? How
Ma'am,
what is the size? What is the nucleus like?
ma'am, size 30 to 40 micron, and it will be the nucleus is fine chromatin nuclear is seen, and cytoplasm will be mostly bluish, and while the metaplastic cells will show angulations.
Okay. So it's in this field, I can see a lot of, and I think all others will agree that there are a lot of intermediate squamous cells.
Yes, ma'am. And most population of intermediate cells are seen.
And I don't think there is any metaplastic cell in this field.
Ma'am, some of the cells that have some angulations or sharp borders, I thought it was metaplastic cells.
I feel that they have more. Can you see my cursor here? Okay, I'll try to use a pointer. Okay, can you see the pointer now?
Yes, ma'am.
Yeah. So if you're talking about this cell, which is slightly smaller, and if you feel that this has angulation, just let me tell you that these are not angulation. The cytoplasm is just folded. Here again, you can see the folding of the cytoplasm. So here again, you can see some folding of the cytoplasm. So when does this phenomena happen with the intermediate cells, and why does it happen?
Ma'am, due to progesterone.
Yes, persistent
These are
progesterone.
navicular cells known as
They
navicular
become
cells.
boat-like or they become navicular
Like,
cells.
yeah.
And this is particularly seen in which condition?
I mean, pregnancy.
Yes, it is seen
Progesterone effect. Yeah.
Yeah, and with persistent progesteronic stimulation due to any other cause apart from pregnancy, when you can get this? Hormonal intake. People who just take hormones, OC pills, so they have that continuous stimulation with the progesterone, and there is not the normal cyclical changes that should be going in a woman's menstrual cycle is not going on. So you have these types of cells predominant. And of course, at the onset of the menopause, again, there is loss of estrogen. The estrogen is less and you have more progesterone. So that time also you'll get these cells. Now, if we go to the, now you can see some orangophilia over here. I think if we spend some time on the normal cells, it will be a little better for us in the coming slides. What is this orangophilia due to?
Due to keratin, superficial cells.
No, exactly. This is not keratin because the cervical and vaginal epithelium is a non-keratinizing type. So this is glycogen. These cells are laden with glycogen. They are the cells which have the maximum amount of glycogen, which sustains the 3-4 layers of intermediate squamous cells, and of course the cells that are on top, the superficial squamous cells. So this is the classical color which is taken up with the papinocolor polychromatic stain. Okay, now again, what is this picture showing?
Mostly intermediate cells and
yes. Now coming to the size of the nucleus of the intermediate cells. So what is the size like? And what have you read about it?
ma'am, nucleus is fine chromatin. And
no, you tell me
size.
first the size.
Size, ma'am, I'm unable to recall the size.
Okay. So by and large, if anybody else knows, all of them are unmuted or only Rachna is unmuted? Okay, what's the size like, Rachna? It's of the size of the lymphocyte, around 7 to 8 micron millimeter in diameter. Do you agree with that? Here you can see the various nuclei. Now, why is it important to know the size of the nucleus?
Ma'am, to inspect whether there is any nucleomegaly reactive cellular changes.
So the size of the intermediate cell nucleus is the benchmark for comparing the sizes of all other nuclei when you are seeing the lesion, the LSIL or the HSIL. So this size will be the benchmark for comparison. Also the nuclear chromatin. Now tell me, what is the texture of the nuclear chromatin described as?
Fine chromatin, fine granular chromatin.
Yes, so it's a vesicular type of chromatin. Yeah, and this is abundant cytoplasm is there, and the cell is large, 30 to 40 micron millimeter in diameter. So this is the size of the nucleus. Constantly remember and keep referring to whenever you are seeing a pap smear, whether it is conventional or whether it is a liquid-based preparation. So this is the nucleus size of the ICM, that is intermediate cell nucleus, is the benchmark for comparison. Now, what are you seeing in this slide?
Ma'am, again, intermediate cells and
But I think there are some mature squamous cells also.
mature squamous cell.
So this is a superficial squamous cell. What is it containing? What are they called as? What are those granules you're seeing, blue granules inside?
Keratohyalin.
Yeah, so they are keratohyalin granules, which are commonly seen in the superficial squamous layers of the cervical epithelium. Now, these are also, now how do you differentiate a superficial cell from an intermediate squamous cell?
Superficial cell will have pycnotic nucleus.
First, come to the size of the cell. Is it larger or smaller than the intermediate?
It is larger than intermediate. It is the largest one.
Yes, so it is larger. So what is the size of a superficial squamous cells in terms of micron millimeter?
Approx 30 to 40 micron.
Okay. It can be slightly more also, but okay. So that's the size, because for the intermediate also we said 30 to 41.
But it is slightly larger than that of intermediate one.
Yes. What is the other difference?
Ma'am, pycnotic nucleus
Yes,
present in
it is
superficial cells.
very dense, pycnotic, structureless. For the intermediate cell, we said that it is slightly vesicular and you
Vesicular
can
and
see
fine.
the chromatin granules. But here it is mushed and structureless. So as the cells are maturing, the nucleus becomes structureless and pycnotic. And then ultimately what happens to the nucleus? It is no longer there. It is shed off and only you get these wafer-like anucleate squams on the topmost layer. Now, what is this again?
Ma'am, superficial as well as intermediate cells. And
yeah, so these three cells are the classical intermediate cells. Again, what is the shape we will call it?
Polyhedral shape.
Yeah, navicular type of cells. Here again, you're seeing some, yeah, there is some clearing of the cytoplasm. And see, the nucleus is like a lymphocyte, like 7 to 8 microns. And you can see some rim to the cytoplasm, an inner rim and then an outer rim. And the inner rim is slightly folded. Why this is happening? Because it's trying to accommodate the large amount of glycogen which is present in these cells, and the margins of these cells are folding. So this is nothing to be confused with wire looping that we will see later on in LSIL smears or in the coilocytotic atypia that we find in LSIL. So this rimming is not that rim, but it is just folding of the periphery of the cellular margin. Same is happening over here. You can see my cursor, I suppose.
Yes.
Now, again, I have added in this PPT of mine, the file that I'm sharing, I have added some pictures. Maybe you have not seen them in your cases that I have circulated. So again, here you're seeing a lot of superficial cells over here with lot of What are those granules inside? You already told me.
Keratohyalin granules.
Yes. Now in this other picture, what are you seeing? I'm pointing toward these bodies. What are they? And something has happened to the cytoplasm.
Cytolytic.
Yes, I've already written. There is abundant cytolysis.
cytolysis.
And if this cytolysis is excessive, and this is a phenomena very typical with intermediate cell predominance. So when the cytolysis is excessive and you get a lot of bare nuclei in the smear throughout the smear, then it is a quality indicator, and then it becomes an unsatisfactory smear. So we will come back to what is a satisfactory smear. Before that, I think I gave you all these pictures. What are these cells?
Those cervical cells of a different view.
What is this view called as?
This transverse.
It's an end-on view. So you get a honeycomb pattern. And this is the picket fence pattern, which can be from a lateral view. And what is this smear? These are the conventional smears. What is this? This is an LBC smear. So what is the pattern that you're seeing here? Something like cartwheel. So it's a distorted sort of cartwheel. So why this is happening in a, and you're getting a lot of single columnar cells. Now, how many columnar cells should you get to call it a satisfactory smear? Of course, that is not the criteria, but to mention that you have seen the glandular cells.
Greater than 10 endocervical cells should be present.
So that you are sure that the smear is coming from the transformation zone, or your spatula has touched the squamocolumnar junction. So minimum of 10 cells, columnar cells you should see. But what is the adequacy criteria otherwise?
Ma'am, 8 to 10,000 cells for conventional pap smear and 5,000 for LBC.
Yes, minimum of 5,000 squamous cells.
Squamous cells, yes.
Squamous cell. So has the adequacy criteria changed over the years? Previously, adequacy was taken as the presence of glandular cells or metaplastic cells in the smear. But currently, with the revising Bethesda classification from 2001 and the last in the 2014, it's become very clear that the number of squamous cells is more important and should be sufficient. The numbers that you have told just now, they are more important. But if not necessarily, if you do not get glandular cells, that shows that the squamocolumnar junction has not been touched upon, but the smear does not become unsatisfactory. You got my point?
Yes.
So what do we do when we see the glandular cell in the smear? We mention that transformation zone component is seen. So when you were describing the slide report to me, when you had already framed a report, TZ component C has to be mentioned. Okay. Now, what are these different types of cells that I'm showing you here?
Ciliated columnar, indicating that there is tubal metaplasia.
Wonderful. So we need not go into more details. And this one, where my cursor is moving, what is the change in which type of metaplastic change you're seeing over here? There's a goblet cell change. Again, it is a type of metaplasia. Yeah, so you're getting these, again, see the tinge to the cytoplasm. There is a lot of mucin and the cells are distended with mucin. This is the classical color that is taken up by the mucopolysaccharides, which are present in the mucin as one of the chemicals with the pap stain. So the nucleuses become eccentric and they're looking like columnar cells having turned to goblet cells, which you can sometimes see in the nasal epithelium, bronchial epithelium. Agree?
Yes.
So this is that type of change. Again, here you are having that similar type of change. Nucleus has become flattened, pushed towards the periphery, and the cytoplasm is distended. Now we move on to next. What are these cells that you are seeing? They're very tiny.
Inflammatory cells covering, obscuring the
No,
stems.
no, I don't think they are inflammatory cells. I'll magnify them for you. So now, can you comment? See, these are very tiny basal cells which are present in the beneath the glandular epithelium. They are the regenerative cells that actually which are present beneath the glandular epithelium, and they are the cells that undergo metaplastic change, and then they create either they have that potential to create either the columnar epithelium or the squamous epithelium. So just beneath this columnar epithelium, you have the reserve cells. So these reserve cells, they are very small, round or triangular cells, and then they can come in the smear in such large numbers, and particularly they come when the epithelium is thinned out in atrophy. Women undergoing atrophy, the epithelium is very thin, or your spatula is scraping material higher up from the canal, where directly beneath the glandular epithelium you will have this reserve cells present. So here you can see some amount of reserve cell hyperplasia, and that is being represented in the form of these small round, oval or triangular cells, and they should not be mistaken for many other factors which we will later on see. Now, what are the cells beneath you're seeing? These are all
Superficial cells. Superficial and intestinal.
Yeah, so this I had just kept to let you know that sometimes you do get reserve cells. It's very unusual, but then you do get reserve cells in the smear. That completes the findings. Now, of course, coming back to when after every slide, I'm putting this slide where you have to tell me how will you report this smear. Now, come on, tell me, this is the classical Bethesda format which should be followed while you're reporting. So what was the specimen type?
It was conventional pap smear.
As well as LPCA. I've showed you. So, okay, you can, I mean, each time we will have pictures from both the type of smears. Now, next.
Specimen adequacy, transformation zone component was present, so the smear was adequate for evaluation.
No, first transformation zone component was seen, it was adequate for evaluation. That's not correct. Because there were sufficient number of squamous cells, the smear was adequate for evaluation. Got it?
Yes.
And as an additional point, you're going to write transformation zone component seen, because you saw those glandular cells in whatever number, but at least 10 cells you must see. Okay?
Yes, ma'am.
I've again written here, which you already told me. And then you what you want to add over here in the general categorization?
Ma'am, it was negative for intraepithelial lesion and malignancy. Atrophy.
Why atrophy? You saw
Perimenopausal smear.
It's a perimenopausal smear.
Perimenopausal smear.
Yeah.
And
or it's an intermediate type of atrophy, where you get predominance of the intermediate squamous cells. And in the postmenopause, which type of cell will be predominant?
mostly parabasal and basal cells will be predominant.
Parabasal cell dominance will be seen in the postmenopause, but during the perimenopause, which is almost a 5 to 6 year period, you can have intermediate cell type of atrophy. So that is what you saw. Now, what are these categories? One is the general categorization, then Bethesda puts in interpretation, result, and additional notes content. Now, why this is interchangeable? You can put your interpretation as NILM, or you can use it here also. They have given this as optional. And then if you want to add additional notes or comments, you can write all the description of the smear that you want to put over here. Now, in the specimen type and in the specimen adequacy, here you have to, we have skipped this point, you have to add quality indicators. Now, what are these different quality indicators?
Ma'am, whether blood or inflammatory cells, they should
Whether
not
it
be
is
obscuring
obscuring
the pap smear.
inflammation,
Yes.
whether
Yeah.
the inflammation is obscuring the squamous cells and thereby you are not able to see the nuclei properly, whether there is drying artifact, okay, any flaw, or whether the slide was not labeled properly.
Broken. Yeah.
Yeah, when you got it in the lab, or the fixation was not there, there was drying artifact seen. So all these quality indicators you have to mention over here. So that clearly communicates to the clinician that the sample which was received was suboptimal, and thereby we are unable to give a proper opinion. And here in the additional notes, you can write the description of the cells. Suppose in addition to these cells, you want to write some metaplastic cells are seen, they are showing some anemia. Yeah, or sometimes you see some other elements like there is a lot of contamination many a times with fungal filaments, which are not an infective part, but you get this contamination. Contaminants are seen. You can write whatever description you feel like you can write in this additional notes or comment section, which is sort of a description of your, if you want to elaborate the description of this smear that you have seen. But what is most important, even if you're filling this section, you must mention the NILM part. Whether epithelial abnormality is present, yes or no, or whether there is no epithelial, intraepithelial lesion or malignancy, this must be mentioned in the report. Got it?
Yes, ma'am.
Any questions you want to ask? So I think as we move forward, now with this, I just wanted to touch on a little bit on the hormonal cytology, the normal types of squamous cells, and whether or not we do this these days. Previously, lateral vaginal wall smear was taken to count, to do hormonal cytology, and the gynecologists used to bank upon the cytologists to tell them what is the hormonal status of the woman. So for that, we used to count 300 cells, and only generally two cell types are counted, either superficial intermediate or parabasal, or any two of these, because basal cells come in very small numbers in the smears generally. And in the context of the clinical history, the hormonal status was given. But these days we have a lot of immune hormonal assays going on, so you don't need to count the cells and give an hormonal assay. It's just a very sort of imperfect method to give it through the lateral vaginal wall smears. Now, because this smear was having intermediate predominance, so these are, can you read it out for others? These are the conditions where you get intermediate cell predominance.
Intermediate predominance, pre-menarche, pre-atrophy, radiation, surgery, digitalis, antibiotics,
Yeah, a
hormones
lot
like
of drugs,
androgens and
they
cortisol.
lead to loss of maturation and arrest at the level of the intermediate squamous cells. So like various antibiotics and patients on digitalis drugs they are taking, or the patient has undergone some surgery. So that stops the maturation of the squamous epithelium, and then you have to you get intermediate cell predominance. And then, of course, these hormones, androgens and cortisones, steroids being given for different reasons. And androgens, when they take over during the perimenopausal period, that is one of additional cause of having more of intermediate squamous cells. So these are just pictures of how actually it's the role of the gynecologist, how they take a smear, and we have different types. What is this picture showing you? What is this brush called as? What is this? This is a classical IR spatula.
Spatula.
Yeah, so this is the IR spatula, this is the cytobrush, and you have many types of devices. Now, this is a Zale spatula. These are plastic spatulas. So they also have a breakable head. Here you can break the neck at this point and leave the end which has collected the cells into the vial, and so you can harvest more cells. But with a wooden IR spatula, this facility is not there, and the wooden IR spatula is the commonest being used, particularly in the developing countries. But you have this rover's brush or the cytobrush, coming with the LBC material, LBC vials, and this is being used. Now, what is the advantage of this rover's brush? You must have read. Yes, Rachna?
Ma'am, it is used to attain proper the cells from the transformation zone.
Yes, why? Because it has a conical edge. So the
Edge.
longer end of the brush fits snugly into the endocervical canal, and then when you rotate it, the bristles go on rotating on the surface of the cervix and go on collecting these cells. So one end you have to keep fixed inside the canal, and the second end keeps moving and collecting the cells from the transformation zone. And here you can see this squamocolumnar junction, and the transformation zone is the area from this columnar junction to the farthest point where you can see the glandular openings. So this is the old transformation zone, and you will have a new transformation zone, squamocolumnar junction, and you will have an old one, old squamocolumnar junction. So in the area between these two will be the TZ. So the brush nicely collects cells from the both squamocolumnar junction and the transformation zone. Why we need to collect cells from this? Why is it important?
Ma'am, squamous cell carcinoma mostly arises from that region, so we need to inspect that region.
Yes, so cells must be collected from this region. Now, just what are the drawbacks of a conventional smear?
Ma'am, debris or inflammatory cells mostly obscuring the cell, so we are unable to see the actual morphology of cells. And in LBC, all these factors are eliminated.
Yes, and the problems related to fixation, immediate wet fixation, they are also eliminated.
Drying artifact is also eliminated.
Yes, so that is one thing. Now, these are just pictures of how you do this LBC evaluation these days. So you collect, you break the head of the brush and you put it in the vial. And additional advantage is that you can do a
DNA
yes,
testing as well.
yes, reflex
DNA testing.
because the vial is with you in the
Sample.
lab. And if you find any abnormality, you can immediately send it for HPV DNA testing. So I've just given you a broad idea. Now this is if you have the station, or most of the medical colleges and labs are acquiring this is the SurePath system, automated system where you are getting the whole procedure being done, and you get a small diameter. What are the differences between thin prep and SurePath?
Automatic and semi-automatic. Sure. Usability.
No, something in the diameter.
Difference, ma'am.
Yeah, so what are the diameters in thin prep and in SurePath? These are the two basic large companies which are functioning on the liquid-based preparations. So SurePath diameter is around 13 millimeters.
14.
And thin prep is around 22.
21.
21 to 22 millimeters. And this is the conventional smear which occupies almost 2/3 area of the slide. So we'll have to be a little fast. Now we move over to case number 2.
On case number 2, history was 58 years woman with complaints of itching.
Okay, so before we move to the next slide, what all you think of? She's having itching. So what are the causes of itching in a woman? When does she come with this complaint or symptom?
Bacterial vaginosis.
Agreed. What else?
Candida.
Candida.
Candida infection. What else? So what history will you ask to such a woman who's 58 years old?
Discharge color, ma'am.
Pardon?
Discharge and its color, ma'am.
Yeah, whether she's having white discharge, whether the discharge is foul smelling, what is the color of the discharge, right? What else? Won't you ask her history of diabetes? That's one of the common symptom in diabetic women. And then they acquire these infections very commonly, the Candida infections or the Trichomonas vaginalis or the that he talked about just now. So now here you have, I had given you these slides. What are you seeing? Please describe. First, the left-hand slides.
Ma'am, the sheets of parabasal cells.
Okay.
Uh,
In addition to the sheets, what are you seeing?
Endocervical cells.
No, not as yet. And which preparation is this? Both these, which do you think is the preparation?
Conventional.
No, see, this is classically a very homogeneous preparation, uniformly spread. I wouldn't call it a monolayer preparation, which all the companies they claim that they have liquid-based preparation. Their company gives you a monolayer because there is some overlap. Definitely, there is overlapping of the cells, and definitely there are thicker and thinner areas. Now, this is a slightly heterogeneous, not so homogeneous. But and this is because you have, when you have abundant cellularity, you do get thick and thin, slight thick and thin areas even in the liquid based preparation, but the cells are generally not obscured and you can see them nicely. So I agree with you that these are all parabasal cell clusters, but you are having a lot of single parabasal cells also in the smear.
Yes.
So that is what I wanted. Now, how do you describe them?
Ma'am, they are
One that are single.
round oval cells, ma'am, with hyperchromatic nuclei, high NC ratio.
I agree to round to oval cells, but not the hyperchromatic nucleus and not to the NC ratio. Suppose we come to this area. You can see, no, my pointer, the hand
Yes,
moving
ma'am.
around.
Yes, ma'am.
Yeah. So what is the size of the cell? What is the size of these cells? Then you have some of these cells also. These are which the larger cells are the
Superficial
superficial.
smear. Yes, ma'am.
And the smear predominantly is comprising of smaller round cells. So what are they?
Yes.
Are the parabasal cells.
Parabasal.
So it is a parabasal predominance that is which is seen in this slide. Here again on the right side, you are seeing those sheets and then you are seeing the para. Now one thing has happened that the some of the nuclei in the parabasal cells, like this one at my pointer, is showing some pycnosis. So that's just a degenerative phenomena. But like this parabasal cell, it is showing a round nucleus, which is in the center of the cell. Again, you are seeing this one. So you're seeing different sizes and different shapes of parabasal cells. Can that happen? Now see, the squamous epithelium is a dynamic epithelium. Maturation is continuously going on from the basal epithelium to intermediate to squamous cells. So between the parabasal cells becoming totally mature to intermediate squamous cells, you are going to have variation in sizes of the cells and variation in the nuclear appearance. So, but by and large, what is the size of a parabasal cell?
Around 15 micrometers.
15 to 20 microns in size, and then you have a centrally placed nucleus which occupies around the 50% area of the cell. So everyone agrees that this is these are all parabasal cells. Now this is a conventional smear. The ones we were seeing were these one were the LBC smears.
LBC.
What is this on the left side?
Sheet of parabasal cells.
Yes. So why this you're getting so many sheets? We did not see these sheets in the first case because there were more of intermediate squamous cells. Why? What keeps them holding like this? And why parabasal cells come in such tight clusters? Okay, I leave some things for you to read because we are short of time. Here you can appreciate the parabasal cells and the variation in size. Now see, these are the deep parabasal cells. Is the nucleus normal? This one?
Yes, ma'am.
It's normal. It's almost
Normal.
occupying 50% of the area. How does a normal nucleus, when do you call it as a normal nucleus?
Ma'am, when it's more around 50% of the cytoplasm and nuclear membrane is regular.
Yes, the nuclear membrane is smooth and regular. There are no notches, there is no irregularity of the nucleus. And then the nuclear chromatin texture, that is also uniform and homogeneous. And it's not hyperchromatic. And now these are the more larger parabasal type of cells, the ones which are getting mature and becoming intermediate type of squamous cells. So right from the deep parabasal cells to more mature parabasal cells and some more mature intermediate type of cells are seen. Now this, had I shared this picture for you?
Ma'am, sorry to interrupt. Someone in the chat has asked regarding your previous picture on parabasal cells, whether perinuclear halos are present in those cells.
In this slide, was it, or in this?
Yes, ma'am, in this one.
No, these we won't call as perinuclear halos. Okay, this is just a slightly clearing of cytoplasm, endoplasm in the parabasal cells, and sometimes when there is a metaplastic phenomena, it's very difficult to differentiate between parabasal cells and the immature metaplastic cells. But we wouldn't comment on these cells because the cytoplasm is more clear and probably it could be degenerating also. Parabasal cells generally have a dense cytoplasm. So there is no perinuclear haloing in this. Am I clear?
Yes, ma'am, thank you.
Yeah, that's good, Ruchi. You can ask in between what are the questions. Now, coming to this picture, you can see what are you seeing, Ajit? Tell me.
Ma'am,
Focus on all of these. There is some quality indicator which I want you to comment on. We have talked about quality indicators.
inflammatory cells.
No, there are no inflammatory cells, hardly any.
Bare
Again, this is
nuclei.
pardon?
Bare nuclei.
There are a lot of bare nuclei. You're right. Anything else? I just want to tell you what happens, what are the different types of atrophic smears that you get, and what is the confusion of the atrophic smear with high-grade lesions and mistakes that are made in overdiagnosing these normal atrophic smears. So you have abundant cellularity. You at a glance in this slide, you're seeing a lot of bare nuclei, which can confuse you to a dysplastic lesion, throwing away bare nuclei. Now here you have this cluster of parabasal cells like you saw in the previous slides.
Yes, ma'am.
But what has happened to this? There is a very prominent drying artifact in this slide. Do you agree? The nucleus texture is not seen very well, and there is a drying artifact in this. And because of the drying of the cervical epithelium in atrophy, perimenopause, or postmenopause, generally when you smear the material onto the slides, the cells, they are stripped of the cytoplasm, and only the bare nuclei, they remain on the smear. So you have so many bare nuclei because of that factor. And then you have a granular background. Let me see if I have one. Yeah, then you have a granular background that confuses you with the necrotic material which is present, and these bare nuclei of different sizes, and this syncytial like clusters can confuse you to high-grade lesions, and people sometimes give a false positive report of high-grade lesion. Agree, Ajit?
Yes, ma'am.
Yeah, so I'll show you this is what preparation do you think it is? You must be having one of LBC in your department.
Yes, ma'am.
Yeah, so this is a LBC preparation. Again, you're getting a lot of parabasal cells.
Parabasal
They are
cells.
Yeah, now here you are seeing less sheets, and they are coming from different levels. Now you're getting these mature intermediate squamous cells.
Yes.
So I just wanted to highlight that granular background in this. If you can appreciate, I'll try to focus. See, sometimes this granularity you can see in the background. Appreciating it?
Yes, ma'am.
So that, and this enlargement of the nucleus is because of the drying artifact, which gives the site, there is cytomegaly as well as there is nucleomegaly. But how will you differentiate? There is a structureless nucleus. The nuclear margins are very smooth. So still these are benign cells. They are not pre-malignant cells or dysplastic
Yes.
cells. Again, here you are seeing some granular background in this also, and that is a normal part of any atrophy. And that should not, you should be aware of these findings. Now, whenever there is such dilemma, what do you do? Now, see, in addition to the drying artifact, the granular background that you get, and these bunches of these bare nuclei, there you saw, you told me that there were a lot of bare nuclei, but they were not well preserved. Now here there is better preservation. This is a LBC smear, and you're getting these bare nuclei. These also can create confusion with high-grade lesions of the small cell type. And then sometimes there is molding of the nuclei in these, and then again that can be that can create with multiple neoplastic conditions, right from the endometrium to the high-grade lesions of the cervix of the small cell type. So you should be aware of these findings in the atrophy smear. Okay, and we'll try to just move a little faster. Now, what is this? I had given you this slide also. Ajit?
Ma'am, parabasal cells, ma'am, or inflammatory cells.
No, not all. And these are all parabasal cells. Agree?
Yes, ma'am.
They're round, small, with a nice nucleus in the center or slightly eccentrically placed. But what is this group of cells? This is an atrophic smear from a female, say around 55 years old. But what are these?
Endometrial.
No, endometrial cells are not so large. They are again the parabasal cells with persistent irritation, persistent atrophy setting in before the final atrophy sets in. When all the cells become parabasal uniformly, you do get such enlargement of the nucleus. Now, these are still benign cells. How do you, why I'm calling them still benign? Because
The
of which
nuclear membrane is irregular nuclear membrane.
yes, one thing, and there is very, how's the chromatin texture?
Homogeneous.
Yes, it's homogeneous, evenly distributed. Chromatin is there all throughout the epithelium. Otherwise, you get clumps of chromatin in a dysplastic nuclei. So again, these are all reactive cellular changes associated with atrophy. Okay, just like you get reactive cellular changes associated with inflammation and repair. So this is one feature which you get in atrophy because of the constant irritation and constant persistent progesteronic stimulation which is there in the hormonal phase of that woman. And now if you focus on the single cell that I have put here, there is enlargement of the nucleus over here.
Yes, ma'am.
Again, this is a very large parabasal to intermediate, I will call it. The nucleus is slightly larger than that of a parabasal as well as an intermediate cell. So it is neither a parabasal cell nor an intermediate cell. But if you see the cytoplasm, what will you call it?
Parabasal.
No, cytoplasm is abundant. It is becoming
intermediate.
translucent. Yeah, so it is coming towards an intermediate squamous
Squamous.
cell. The nucleus is still large, favoring a reactive parabasal cell. So you will get transition of cell types in a smear So always do not carry away and if I ask you, tell me which is this cell, tell me which is this cell. You may not try to, you may not be able to pinpoint and say that just like this cell, this is also a parabasal cell. So you will have many transitions. So you all the time you have to focus on the density of the cytoplasm. If you want to call it a parabasal cell, how will be the cytoplasm? Denser.
Then side.
Thick and dense. And if you are calling it a more mature cell, the cytoplasm will start becoming translucent and transparent as it moves towards superficial squamous cells. So when there is reactive cellular changes, you will get these changes in the nuclei, but you have to keep focusing on the nuclear membrane and even distribution of the
Chromatin.
chromatin.
Yes.
Very well read. Now see, again, I want to show you another case where you have reactive cellular changes with atrophy. What is happening to these cells? They are looking dark. The nucleus is looking large.
Hyperchromatic. Yes, ma'am.
Yes, and what is the background looking like?
Background.
Granular,
Granular.
dirty and granular. So these are all the changes that you can get with drying artifact or with, even if there is no drying artifact, persistent stimulation of hormones can give you rise to such large dark cells which can be mistaken for atypical squamous cells of different category, either ASC-US or ASC-L, depending on the maturity of the cell. And now this is a liquid-based preparation where again you are getting, now the granular material in liquid-based preparation slightly keeps clinging to the squamous cells. So you have this granular material which is clinging to the parabasal cells. Okay, we'll move on. Now I don't know what is come up. Now you can, what is this sheet of cells? Again, she's an elderly female. These are parabasal cells.
Parabasal.
What has
some
happened to the, huh? Yes.
Some cells have irregular nuclear membrane.
So you're focusing only on one thing. What has happened to the size of the nucleus? It's become slightly enlarged. So you
Yes,
feel
ma'am.
like as if the NC ratio is raised.
Yes, ma'am.
So,
Yes,
and the nuclear appearing little dark. So would
yes.
you like to call it as HSIL?
HSIL.
Other abnormalities?
SH.
Maybe ASC-H you want to call it.
Yes,
But we know that atrophy, persistent stimulation of hormones can cause all this. And plus the sheet is very flat. You can see very nice junctions between the cells. In a high-grade lesion, you will get syncytial clusters overlapping of the nuclei in a small area. So this is creating a doubt whether or not it is reactive cellular changes associated with atrophy or it is ASC-H. So what do you do in such cases? There is a estrogen test. What is that test? Yes, tell me. You ask the woman to apply estrogen for 15 days or 3 weeks and come back again. Local topical application of estrogen cream. And what happens with that cream?
Ma'am, if it's due to atrophy, then the changes will go away.
Yes. So there will be maturation of the epithelium.
Yes, ma'am.
So these cells will mature, and if there are if they are dysplastic, nothing will happen to these to the dysplastic cells. They will rather stand out very clearly in the background of more mature cells, and then you will be more confident in reporting them as sketch or a high-grade lesion or whatever you feel like at that point of time. So this estrogen test comes very handy, and this should be followed. And we should indicate in our report that repeat smear after topical application of estrogen, so that, or our dilemmas are removed. Now, this when you have this type of atrophy and this dilemma, the same dilemma is forward with the biopsies also. Sometimes the patient lands up because of our reports of ASC, they land up in biopsies, and in the biopsy also you start seeing such nuclei. Now here again the dilemma remains. Here you can see the squamocolumnar junction. At the junction you are getting these cells, but according to me the polarity is well maintained in this. So here again, I'm not able to decide whether this is a high-grade lesion or it's just a reactive hyperplasia or reactive cellular changes. Then you have to resort to P16 staining, and in the P16 staining, they turn out to be negative, and then only you are very sure that these are all reactive cellular changes. So atrophy is a very difficult zone sometimes to interpret because of the hormonal atypia that it creates, to the extent that that atypia carries forward even in the biopsy, and then you have to really juggle with the monoclonals. After adding monoclonal antibody only you can clear up the confusion. Okay, so is that clear to you?
Yes, ma'am.
Now, just to show you few clinical pictures of an atrophic cervix. See how thin the epithelium becomes, that when it's just parchment-like, it's very delicate and thin, and with the touch of the spatula, the cervix starts bleeding because the blood vessels are the stroma which is present beneath the epithelium is very close to the surface, and you have these bleeding spots, or it just tears off and you have this strawberry type of cervix. And this is a common appearance with the colposcopy. Now, what are these? I had given you these pictures also. At a glance,
Bare nuclei with inflammatory cells.
there are a lot of inflammatory cells on the right side, but what are these? These are giant cells.
Giants.
So, do you get giant cells in atrophy?
Ma'am,
I thought if you read atrophy, you will read everything about it. So you do get, yes, you do get giant cells in atrophy, and they are just conglomerate of the intermediate squamous cells. Or just because intermediate squamous cells are more sticky, or we call it a crowded type of atrophy, so they are clinging to each other. So you have a common cytoplasmic background with the nuclei in these are not histiocytic giant cells. This one is a histiocytic giant cell, which has engulfed the polymorphs. But these are all giant cells that you can find in atrophy. So, any other condition where you can think of that you get giant cells?
Radiation changes.
Yes, very good. Anything else?
Uh,
Histiocytic type of giant cells. Commonest condition in India.
HPV.
That is an infection. Yeah,
T-
in HPV you can get multinucleation with other features. Tuberculosis.
Maybe.
That's another condition. And when you do get tuberculosis, endocervicitis is common. And there you get these giant cells. We'll not go into that details because now how will you report this? Come on. The reporting format has to be thorough and by heart by the time we are over with our session. What was the specimen type?
Ma'am, liquid based cytology.
Okay, you did see some conventional smears also. Next.
Specimen adequacy adequate due to the number of squamous cells.
Agreed. There were sufficient number. So specimen, what will you write there? Adequate for evaluation.
Evaluation.
That's the term you use, adequate for evaluation. What next you will write?
General categorization, ma'am.
No, before that, what will you write? Transformation zone component. I told you it's very essential to write. Did you see that?
No, ma'am.
You did not see columnar cells. Did you see metaplastic cells?
Metaplastic. No, ma'am.
You did see. You were not confident. So some smears were showing that. But if you have not seen, you will write transformation zone component is not seen. Meaning that you did not see endocervical cells. You did not see any metaplastic cells. General categorization will be?
NILM, epithelial lesion or malignancy.
Right. Now you want to write anything in the additional notes, and for this patient I have written something.
Yes, ma'am. Repeat smear. Uh,
So in
ma'am,
some of the smears we had a doubt
yes, ma'am.
whether or not there is dysplasia or ASC-H, or so we want a estrogen test to be done in this patient. Okay.
Yes, yes.
So that comment will come in the, and there if you want to write why, you can even go on elaborating why, because the nuclei were large, they were dark, or the NC ratio looked a little more, but the membrane was smooth. Whatever you want to describe, you can pour your heart out in this notes or comment section. And why is it essential to be very descriptive and write all the findings in the first go? Because your report keeps circulating in amongst other pathologists, so they should know why you have whatever you have written for a reason. Because you were seeing all this, you have advised a estrogen test. So let there be documentation. It's always very good to give a description or fill your additional notes section. But what is more important, to be very brief and clear whether NILM or epithelial abnormality, yes or no, and write NILM, yes or no. Okay?
Yes, ma'am.
Any questions over here? Otherwise, we go to the next case.
Ma'am,
Coming
there's a
to-
question. Can we use P53 with P16?
Yeah, we can. We can use. Rather, we should be using P16. That will tell us whether or not there is a P16 is a surrogate marker for HPV infection. Agree?
Yes.
Right? Huh. So we can use that also. So let's go to case 3.
Next case is 40 years old lady,
Ghazal.
LMP 9 days back.
Okay, 40 years old lady, LMP 9 days back. What are you seeing?
We can see endometrial cells arranged in exodus balls, and they are nuclei is small and similar to the size of an intermediate squamous epithelial cells with inconspicuous nucleoli and scant amount of cytoplasm.
Agreed. So you feel all these cell clusters are endometrial cell clusters.
Yes, ma'am.
What is this appearance?
Ma'am, this is top hat appearance.
Okay, so what are the components of this top
Ma'am, it
hat?
has a central part is composed of the stromal cells, and it is surrounded by ma'am, glandular cells are surrounding the stromal cells.
These are the endometrial epithelial cells.
Yes, ma'am.
Outer endometrial epithelial cells and central stromal cells. Okay. Now, what are the days when you get a post-menstrual cycle?
Ma'am, it
Which
is
days you expect them?
yes, ma'am, it is usually seen in the first half of the cycle, and it is seen after the 25th day. So, ma'am, between 14th to 25th day is it is usually not seen, and it's considered abnormal.
Not seen, I thought you were saying. So, exodus type of if you are calling this as exodus, generally you get between the 6th to 12th day of the cycle.
Yes, ma'am.
So, the endometrial cells stop shedding which day in a normal cycle?
After 14th day, 12th to 14th.
Yeah, we take it as the 10th to 12th day. They should not be at all seen after the 12th day. And if they are seen, what do we do?
Ma'am, we have to report it.
Yes. In which section?
Ma'am, in others where we can write endometrial cells are seen.
If I go directly to this, now what will be your specimen type? I'll go back again. Specimen type, tell me.
Ma'am, conventional.
Okay, conventional ABC both. Now, this category, what you are going to write?
Adequate for evaluation and transformations on component not seen.
Okay, then
Negative for yes, ma'am. NILM, yes. And in
Yes.
others, we can mention endometrial cells are present.
Mhm.
If it is beyond 12th day or beyond 45 years of age, we have to report irrespective of the day.
Now, this change has come in with Bethesda classification?
2001, I think.
Yeah, up till 2001, it was, you had to, the age limit was 40 years.
40 years, yes, ma'am.
But with the last 2014 classification, they have made it 45 or more than 45 years of age. If you see endometrial cells out of phase, you have to just mention it. It's essential to mention. But if you see it before that, before 45 years of age, it's not very essential. It does not carry any clinical significance. So even if it is out of phase, that is what they are saying. But then that is too much of risk. If we see, we can still mention it. But if you have to ideally follow the Bethesda system, then they are saying that even you may not mention it even if it is out of phase. Now, by out of phase, everybody be very clear that we mean that if you are seeing endometrial cells after the 12th day of menstrual cycle. Okay, and we have talked about this. Any comments you want to add over here? You want to describe anything, Ghazal? Were you very sure that these are endometrial cells? Did you have any doubts whether they are endocervical cells or clusters or balls, or you're finding any glandular abnormality? Did you confuse with anything? No? So you were very sure that these are endometrial cells. Now, did you want to know any history? Ask them anything?
Ma'am, we can ask about history of endometriosis or intrauterine devices.
Right. So you have to ask them whether she's a copper T wearer or if any other intrauterine device is already implanted there. If you get out of phase shedding of the endometrial cells, then all these doubts should come in. You should, if they have not mentioned of the LMP, we should ask them about the LMP also. Now just having a quick look. What is this? See, you get these knobby clusters. And what are the other components of when you get endometrial shedding? What are the other components seen in the smear? Ghazal, you see a lot of histiocytes.
Yes, ma'am, we can see histiocytes and we can see stromal cells along with
You
endometrial.
can see some calcification.
Yes, ma'am.
Calcified bodies can also be seen. Now, again, this is another endometrial cell cluster. See, there is so much of overlap of these cells. And even the margins are irregular. Sometimes you start doubting about glandular abnormalities. But you have to keep focusing on the nuclear features. Here again, you are seeing such cell balls. These can be mistaken for glandular epithelial abnormalities. For that purpose, I had put. Now, what are these cells?
Ma'am, when we can see the presence of cytoplasmic vacuolations in these cells, ma'am, it is displacing the nuclei to periphery. Usually, it is seen with the presence of IUDs. If the patient is using IUDs, so we
Yes.
can see this appearance, ma'am.
So you can get these bubblegum cells or vacuolated cells, and you can mistake them for glandular adenocarcinomas coming higher up from the ovary, shedding from the endometrium. So if you have any serious doubts, that's why you want to know whether she's a IUD wearer or not. And then these are called as chewing gum cells or the bubblegum cells. So then you have to focus on the background of the smear and diligently search for more endometrial cell clusters or the classical exodus type of cell clusters and focus on the nuclear features. Now again, see some of these cells in this picture. See how this vacuolation of the cytoplasm, and that's why it's important for you to know the gynecologist must mention on their requisition form regarding the LMP of the patient, and before reporting we also should ask them for the LMP last menstrual day of the cycle. Again, I'm showing you some more vacuolated cells. Now these can also come as a part of these could be cervical cells. If, they are not as small as the endometrial cells, but they can have vacuolated cytoplasm even as a part of degenerative changes or hypersecretory activity. And generally, endometrial cells will be smaller cells with more degenerative features, inconspicuous nucleoli. That is what is important. And we have to exclude adenocarcinoma when you have serious doubts about the vacuolated or signet ring type of cells. Anything you want to add, Ghazal, or any doubt? So this case was particularly to show you the presence of endometrial cell clusters in a smear, which happens very commonly, and then the dilemma that it creates, and the reporting system, the report how you have to frame in such a patient. Okay, this other category is very important for, and it is specially allotted for endometrial cells, mentioning about them. Now coming to case number 4, Mannat.
Ma'am, one of the residents in the chat section, they have asked how to identify endometrial cells. I'm sure,
Yes.
I mean, you've explained all of that, but if you would like to answer this.
Yeah. So in the end, I was just trying to tell you once again that endometrial cells, they come in tight cell clusters and cell balls. They are very small cells as compared to the endocervical. The cells, the nuclei are smaller, although we say that they are of the size of an intermediate cell, but definitely they are much smaller. They have a chromatin which is more smudgy, and you have an inconspicuous nucleolus, and they typically come like this in 3-dimensional balls. And why this happens, as the endometrial cells, they are rolling down from the endocervical canal, from the endometrial cavity to the endocervical canal, so they start gathering upon themselves. So you generally get the cell balls being formed while they are rolling down the female genital tract and coming onto the surface of the cervix from where they are scraped off. So you will generally get these in small clusters. Here you get like these knobby clusters, and tubular branchings also sometimes you can get. Now there are pretty many appearances. I could not put all of them in the. So you generally get such tight clusters, and then you have to correlate it with the LMP also if you are in doubt. Otherwise, they have a very classical knobby appearance. See, in this LBC preparation, typically in the LBC preparation, they stand out onto the surface. And they are slightly out of focus as compared to the background. Okay? And this exodus appearance is another very classical appearance which is seen, but generally you will get them in a cell ball pattern. If this is dispersed, the nuclei are very degenerate and small. Case 4.
It was a 27-year-old woman who complained of foul-smelling vaginal discharge.
What are you seeing?
Here, I saw Trichomonas in the inset image. We can see
But
this
the general
appears.
image, but this image, what is it showing?
Adequacy, adequate cellularity, and
Let's consider that. Okay.
inflammation.
Lot of inflammatory cells are seen. What are these?
It's slightly obscured because of the inflammation.
Right, you're right. Okay. But what are these? These balls you are seeing, multiple balls you are seeing.
Neutrophils present as polyballs, usually in Trichomonas infection.
Yes, so these are cannonballs or polyballs that you see because of the Trichomonas infection. That is one indicator. When you start seeing these balls in the smear, you know that you have to look for TV bodies. So now you, in the inset, you said you saw the TV bodies. Can you describe the structure quickly? Here also you see.
Trichomonas is in shape, and mostly it is be cyanophilic cytoplasm, and the nucleus is eccentric.
Mhm.
Flagella we can see mostly, like sometimes we can see the flagella, but that is more prominent in LBC compared to a conventional pap smear.
I think in both you can see them best in the hanging drop preparation, but otherwise the flagellum that is generally lost, it is so delicate that in the preparation of the smears, both in LBC and conventional, it is lost. Okay. Now what are you seeing here?
Perinuclear halo.
You will see perinuclear halo. So here you can see this. So how do you differentiate this halo from a halo that will be seen in a HPV infection or in a coilocyte?
Coilocyte, the perinuclear halo it's a little larger, and there is peripheral condensation of the cytoplasm, which we do
Here
not
also
see.
I can see some condensation. So what is the difference then? Isn't it not a coilocyte? See, the halo is also pretty large. That's the purpose they have this. Now, in this coilocytotic atypia, here the halo will occupy almost 2/3 area of the cytoplasm, and you'll have peripheral condensation of the chromatin. And in addition to that, you'll have nuclear abnormalities. Significant nuclear abnormalities will be there.
Nucleus can be seen during.
Yes. Now, the margins of the cavity here you can see is very ragged. Whereas in a coilocyte, the margins of the cavity are very sharp. Another difference is that the halo that you see, the cavity that you see, it's optically transparent. Optically clear rather, not transparent, it's optically clear. Here you are still seeing there is some remaining cytoplasm around the nucleus. You agree?
Yes, ma'am, some granularity as well.
Yes. So cytoplasm is still preserved, and this is a classical moth-eaten appearance which is seen in a Trichomonas infection.
Yes.
So some amount of cytoplasm is eaten up, other part is not being eaten up. The cavity is very ragged. Of course, this condensation is there at the periphery, but it is not because of the chronofilaments that we get in HPV coilocytes. Now, what you're seeing, another thing in the background, very dirty background. So why do you get a dirty background?
Ma'am, because the cells are being broken down and
yes, there is excessive cytolysis. The trichomonas, they are all hanging onto the cells, squamous cells, and then they are being attacked by the polymorphs, and there is lysis of the cytoplasm. Like here you are seeing there is lysis of the cytoplasm that creates a dirty granular background. You can appreciate these trichomonas, and see here again you have this cavity over here. See again there is beginning of the cavity. The halos are small, but the cavity margins are very ragged. These are the tiny bodies which are sitting on the top of the cell. So, what again you're seeing in this? Tell me.
again we see intermediate cells, and we see in trichomonas we seeing the perinuclear halo again in those.
Now, do you think that these are significant halos? No, they are.
Present in so many of the in so many cells here.
Yes. So they are uniformly present in most of the cells. That is it. See here, most. Whereas when you get coilocytes, you get coilocytes starkly present in the smear. Focally, you will see that abnormality of clearing of the cytoplasm. It will not be a generalized phenomena like you are seeing here. And the halo is also just occupying 1/3 area surrounding the nucleus. It's not occupying the whole of the cytoplasm or 2/3 area of the cytoplasm. Got it? Now, what I'm trying to show here?
Ma'am, there's usually along with trichomonas, we also see leptothrix.
Yes, very correct. And you call it as spaghetti and meatball appearance. Okay. So whenever you see leptothrix, you should suspect the trichomonas, and if you see trichomonas, you should also look for leptothrix. Their association is somewhere between 30 to 40% of the time. They will both will be associated with each other. Now, this is just a clinical picture and a biopsy picture in case of Trichomonas vaginalis. You get a classical strawberry cervix, and that appearance comes because of the microhemorrhages or acutely dilated blood vessels which are present beneath the epithelium, and they reach up to the surface of the epithelium, like here, and you can see them as bleeding spots. So you get a strawberry cervix in two conditions. One I told you just before this case. Yes, I did mention strawberry cervix in
very
atrophy.
thinned out.
Yes, in atrophy.
Very thinned out.
Yeah, so there also you get these hemorrhagic patches, and the other reason for strawberry cervix is the TB infection. Now, what will you write in this quickly?
A specimen type we saw both conventional and L.
Very good.
And in adequacy, we'll write adequate for evaluation. CZ component was not seen. I didn't see it in these slides.
Yes.
And some inflammation in one of the slides, the inflammation was obscuring the initial slide.
Yes, so this here it comes here as a quality indicator. Okay, then?
And in general categorization, I'll write NILM.
Right.
And in the interpretation, I will write Trichomonas vaginalis with leptothrix and some reactive cellular changes associated with inflammation.
Wonderful. So what did the, if you want to write additional notes, which reactive cellular changes typical of Trichomonas? What are the 5 that we generally ask the residents during the exams? What are the changes would you like to write over here?
Nuclear halo.
Yes. Dirty background.
Dirty background.
Polyballs.
Polyballs.
So these are the 3 that you always remember. But you have already mentioned over here that you saw the TB bodies. Okay. Polychromatic staining is the other one. The 4th one is the polychromacy of the cytoplasm, that you see 2-tone cytoplasm in these cases. You have pink color as well as the green color of the cytoplasm. That's one feature. I mean, it's generally highlighted in the conventional smears. Okay, very good, very well read. Now, just one tip over here is that because I collect the smears myself, I even do the colposcopy. It's so easy to relate to the problems of the gynecologists. What they do is when the patient comes, they have an erosion over here, which is bleeding, which is the cervix is looking very angry. They just tend to take a smear from such a cervix, which is covered with discharge, blood, mucus, everything. And all of that is transferred to us onto the slide, resulting in an unsatisfactory smear because of obscuring inflammation, mucus, etc. So generally, when you see so much of inflammation, and if you are in communication with your gynecologist on a regular basis, you can always tell them or educate them that these are our difficulties. So better treat the patient with a broad spectrum antibiotic. They do give that whenever the patient comes to them. And then after 6 or 8 weeks, they can take a smear. So when the patient comes back, see how clear the cervix becomes. There are hemorrhages because the erosion is still there, but at least the purulent material has been cleaned off. You can visualize the squamocolumnar junction and take a better smear, and you will get less obscuring material. So what I want to emphasize here is that you should be in communication with your gynecologist if you want to have very good smears and representative material. Coming to case 5, Tapi?
Yes, case 5. History was 35 years and executive screening was done.
Okay. What are you seeing here?
In the we see superficial intermediate cells, superficial cells, nuclear.
And this is which cell is this? Only this slide. Which cell? Intermediate type of cell. Why?
Because the nucleus of the cell is almost the size of a lymphocyte.
Okay.
And
this one. Okay. But here there is nucleomegaly. Cytoplasm is translucent.
Yes.
Okay. Here, which is the cell type?
Here, so we see intermediate type of cells and some
Okay. And here
paravasal cells.
in this, these are
In-
also all mature cells.
Yes, with inflammatory cells.
There are few inflammatory cells, but basically the epithelial cells are all of the mature type. They are either
Yes.
superficial or they are intermediate. Here it's predominantly intermediate. Here you have one or two superficial cells with the other intermediate, and here there is a mixture. And then what is common to all of these cells? Yes, describe. Nuclear abnormalities?
Yes, there is nuclear enlargement,
Hmm.
little hyperchromasia,
Hmm. Why little? There is a significant hyperchromasia.
and
Hmm.
irregular borders.
Okay, here you can see. But what is this? These are two nuclei or this is single?
Two nuclei, binucleated cells,
And these are multinucleated.
multinucleated.
So you have binucleation, multinucleation, hyperchromasia. All features of nuclear ATP are there. How's the chromatin? Texture of the
Coarse
chromatin, how will you describe? Coarse chromatin. So you feel that these are coarse dots or a salt and pepper type of chromatin.
Yes.
Agreed? Now here there are different shapes of the nucleus. Is there any cytomegaly? Do you feel that these cells are larger than the normal intermediate squamous cells? Even this one and this one, there is cytomegaly. Agreed? There is cytomegaly with nucleomegaly. Now what are these?
We see collocytes, binucleated collocytes.
Hmm.
This
Now describe this cell. I've already told you all the features when we were talking about the hydrocyte with Trichomonas infection.
yes, this collocytes. These are squamous epithelial cells with hyperchromatic nuclei and perinuclear halo
Hmm.
with a peripheral limbing of cytoplasm.
Condensation of the or known as biavidity.
Condensation. Yes.
Sometimes there is cracking of the cytoplasm, like you can see here. What are these cells also known as? Balloon cells. Now, what has happened to this cell over here? This connectivity is a little poor. I can't listen to her. Come on, describe this one. What has happened to this? There's a lot of.
This is
Mhm.
also a collocyte with
This is also collocyte. But this, can you appreciate the nuclear chromatin, or it's become smudged, dense and dark?
yes, it's dense and dark chromatin.
So what will you put this lesion as?
Low squamous intraepithelial lesion.
Yes. Low grade squamous intraepithelial lesion, which according to the Bethesda system encompasses both HPV and CIN1. Now, what is one thing which was very common was the cell was large, cytomegaly, and the nucleus was large. So if both the things are enlarged, what happens to the NC ratio?
Normal NC ratio.
So the NC ratio is maintained. So in an LSIL cell, generally NC ratio is maintained, but the nucleus is still enlarged. Now, how many times enlargement of nucleus is required to call it a cell of LSIL cell?
2 times the intermediate.
No, not 2 times.
3.
More than 3.
More than 3 times should be the enlargement of the nucleus. So if the nucleus of a normal intermediate squamous cells is around 7 to 8 microns, so what should be the size?
21 microns.
Yeah, so it will be like more than 20 micron millimeter in diameter. Ideally, it should be 4 to 6 times the enlargement. Now here you can see this knobby endings, whether it is a multinucleated type of cell or it is just lobulated nucleus, we are unable to say here. But here the binucleation is very clear. And then you have this halo around it. Here you have multinucleation. See, the cytomegaly is so significant that there is folding of the cytoplasm. There is hyperchromasia. All other nuclear features are present. So these are the different features which I have highlighted. Can you read it once again for your own endorsement?
Yes, it is a slide of low-grade squamous intraepithelial cells, both HPV and CIN1, seen in both HPV and CIN1. This shows cellular enlargement by and multinucleation, nuclear hyperchromasia, nuclear irregularity, and perinuclear halo.
So these are the classical features which must be present before you can put it as a coilocyte or coilocytotic atypia or LSIL. In bracket, you can write HPV infection only if you see a coilocyte. If you do not see the coilocytotic cavity, but the nuclear features are still conforming to the nuclear features are still significant, it is a CIN1, but we put it in the Bethesda system under the category of low-grade squamous intraepithelial lesion. We'll see some more. Now, these are the features clinically. How do you get them as keratotic warts? So they have a keratinized surface, or you have leukoplakic areas onto the vagina or onto the surface of the cervix, or you have these moist micropapillary lesions, or you have this subclinical condylomas, which are the most treacherous ones. And see how they are present along this squamocolumnar junction. Only after application of acetic acid you can see them, whereas this and this can be seen with the naked eye without applying any acetic acid. But this becomes white only after application of acetic acid. And here you can see these spots over here, they are of a spiky condyloma. So you have different types of HPV lesions which can be identified with the colposcope. How will you report this?
Specimen type is LBC, liquid-based cytology. And specimen liquid in evaluation. On categorization, it is of low-grade squamous intraepithelial lesion.
Yes, it will come over here. It will no longer be NILM. It will come under the epithelial abnormality. But in the specimen adequacy, you have not mentioned transformation zone component seen or not?
Yes, a transformation zone component was not seen.
Okay. What else? Now, would you like to write any detailed comments over here, or you want to advise something?
We will comment upon the coilocytes we saw and the HPV changes.
If you want, you can describe all the morphological changes, so they remain as a document over here. Do you want to advise an HPV DNA test in such a patient with such classical features? And when I told you that she was 35-year-old?
Yes.
Is HPV DNA indicated in a 35-year-old?
Colposcopy.
Colposcopy is the next step. But before that, if you want to do, what is co-testing?
We repeat the test along with HPV DNA.
Why will we repeat when we have a vial of LBC with us? Testing can be done from that only. Now you know that it is LSIL, and LSIL is caused by more commonly by which types of viruses?
HPV virus.
Types generally?
6 and 11.
Yeah, low risk viruses. But there is a chance that because the patient is more than 30 years of age, she might harbor high risk viruses also. And HPV testing is indicated in women more than 30 years of age. And because it is executive screening or screening, she can afford it, we can always advise HPV DNA testing so that she undergoes co-test, cytology as well as HPV DNA test. And if she turns out to be negative for high risk viruses, then she can be followed up at 5-yearly intervals. The advantage of co-testing is that she can be followed up at 5-year interval. But if she is positive for high risk viruses, what is the next step? She will undergo
Colposcopy.
colposcopy. And if there is a lesion, a directed biopsy will be done. So seeing to the individual case and her age, you can always also advise HPV DNA testing or ask them that we have the vial, should we go ahead with this? So that can be easily done because you have the vial with you. You don't have to go in for a second sample. Now in this, I have just written something like differential diagnosis of the perinuclear halos. And you have some of this. Here you can see these navicular cells or intermediate squamous cells where there is clearing of cytoplasm. We saw in the first case also. Agreed? That is one reason which can be mistaken for coilocytes. But again, you have to look at the cytomegaly, nucleomegaly. Nucleus should be more than 3 times the size of intermediate cell nucleus. That you have to constantly keep in mind. But sometimes when it is in the retrogressive phase, you get more of shrunken resinoid hyperchromatic nuclei. The nucleus rather look very small. In a coilocyte, they are shrunken, and then you have to focus more on the this wire looping and optically clear cavity that you're seeing, a large halo or a coilus or a cavity that you're seeing along the smudged nucleus. So you have to constantly keep in mind all the features and try to decide whether it is a LSIL or it is a mimicker or a pseudocoilocyte. Here again you are seeing the superficial and intermediate squamous cells laden with glycogen. What is this you are seeing? This is just simply vacuolar degeneration of the cytoplasm which you get in inflammatory conditions. There is the cytoplasm imbibes lot of fluid, it becomes bloated, the cell looks large, the nucleus looks large, but then how will you differentiate? The details of the nuclear texture they are not seen. The nucleus is rather hypochromatic and the enlargement is not as much. Yes, Candida will also show halo, somebody is writing. Now these are the metaplastic cells that have a two-tone cytoplasm, I think we saw in the beginning. But see, the nuclear enlargement is not as much. The cytomegaly is also not as much. The ectoplasm is slightly denser than the endoplasm. That is the difference which is creating confusion. And these are all situations of pseudocoilocytosis. Again, here you are seeing these metaplastic cells and intermediate. Again, this here you are seeing a metaplastic cell with two-tone cytoplasm. But the significant nucleomegaly that is required is not there. I have kept one slide in the center for comparison. Is that clear?
Yes, ma'am.
So differential diagnosis of perinuclear halos or pseudocoilocytes. The reasons for pseudocoilocytes can be many. Now, just coming to case 6.
38-year female previously reported as ASC-US.
Okay. So now you are aware, you have the form, you know her age, and you are also aware that her previous smear had a report of ASC-US. So naturally, you will look in for epithelial abnormality. And what you see in the smear is this. What are these cells? Describe them.
Ma'am, these are few. Ma'am, there is atypical squamous cells seen with the few with the enlarged nuclei, hyperchromatsia, and irregular nuclear contours. And there is also a perinuclear clearing seen.
No, this one, the one I have magnified. So you're saying it's enlarged nucleus, but is it true? Is it really enlarged, or they are more oval and spindle and
Yes,
in
ma'am.
stacks?
Yes,
So
ma'am.
they are in a stratified manner.
Yes, ma'am.
So they are unlike coilocytotic atypia. Don't of course there is some nuclear pleomorphism. There is anisonucleosis. They are hyperchromatic. Now what you seeing here? This is the LBC preparation. What are you seeing here?
Ma'am, here we also seen the crowding of the cells with the ma'am, cell type over here is the intermediate squamous cells type. With the ma'am, there is also in
These are intermediate. There are superficial cells also.
also, yes, ma'am, superficial cells also, and there is in hyperchromatic nuclei, ma'am, somewhere with the irregular nuclear contours also, ma'am.
Yeah, so there is very dark charcoal-like nuclei you are seeing over here, dense pycnotic. But these are not the mature superficial squamous cells because they are not that spread out, and those large ones, they are all shrunken and compact. Here also, even if these are squamous cells, they are all shrunken and compact. So these are the parakeratotic cells that you can find on the surface of any warty lesion. And is this typical parakeratosis or atypical parakeratosis?
Ma'am, typical parakeratosis.
This is atypical parakeratosis because you're seeing nuclear pleomorphism, you are seeing variation in size, shape, chromasia, pycnosis. So these are stacks of atypical parakeratotic cells. That is what I wanted to highlight in this. Now, what is parakeratosis? These are superficial squamous cells that are small, miniature, keratinized, compact cells, as compared to the normal superficial squamous cells, which are very transparent and spread out. And you have nuclear abnormalities. That's why they are atypical parakeratotic cells. This LBC preparation, you may not get this typical stack of cells or stratification that you are seeing. But the stratification is not normal, then it is a disturbed type of stratification. What is this you are seeing?
Ma'am, here we seen the brown stain represent P16 positive.
No.
Ma'am,
This is
diffuse
a conventional smear. These are just anucleate squams. This is a stack of keratin. This is a keratinous cake which has been scraped from the warty surface of the HPV wart. There are no nuclei. They are anucleate squams. So you can get such stacks of anucleate squams, or sometimes you can get small groups of anucleate squams spread all over the smear, and you can get these type of atypical parakeratotic areas also in the smear. Again, here you are seeing disc keratosis. Now, these are also disc keratotic cells. So, what is the difference between disc keratosis and parakeratosis? These are all parakeratosis, disc keratosis. They are reactionary phenomena. So when they are typical, it is generally found in inflammatory conditions, long-standing inflammations. But when the nucleus is atypical, you start suspecting a warty lesion or HPV type of lesion. So now, what is disc keratosis? Have you read about it?
Ma'am, a premature keratinization, normal
Yes.
mature keratinization, ma'am, of squamous cells.
Premature keratinization in deeper cells.
Yes.
The parabasal type of cells. So there will be more polygonal cells.
Or inducible cells.
Yes, you can see these. They are also shrunken parabasal cells with keratinized cytoplasm, centrally placed nucleus, which is hyperchromatic, and variation in size and shape is seen. So this is atypical disc keratosis, whereas these are more mature cells, but still it is shrunken, dense. Cytoplasm becomes very dense. We know that superficial squamous cells have a transparent cytoplasm, but here it is dense, and they are again stacks of cells here, and the nucleus here is atypical. Here they are anucleate squams. So these are all reactionary phenomena to the inflammation which is going on because of HPV infection. So what will you put this as? These are non-classic changes associated with HPV infections. When you get partial halos, when you get this hyperkeratosis, parakeratosis, dyskeratosis, when you get these rafts and pearls. So see, the biopsy of a warty lesion will be somewhat like this. You have a surface which has a thick layer of keratinized epithelium, out of which some layers will be of parakeratosis, deeper layers will be of dyskeratosis, and these all can be scraped and they can come in your smears like this. They can come in your smears like this. You may not get classical coilocytes which are present here if you do not sample this particular area, but here also there is a partial haloing that you are seeing over here. So these non-classic changes, if you see and report 2 or more such changes, you can report it as what?
Non-classical HPV cytopathology.
Yes, but I had given you something in the history. She came to the
SS with the non-classic HPV cytopathology.
So it has been reported as ASC-US. Agree? So if you get these non-classic changes, which you have to apply strict criteria, you can still report it as ASC-US and advise HPV DNA testing. You were seeing coilocytes, but they were partial. You were seeing a lot of keratinization, which is abnormal. You were seeing atypical parakeratosis, dyskeratosis. So you can choose this, and 2 or more features, if they are present in the smear, non-classic features, apart from classical coilocytes, you can report them as ASC-US. That is the point in this. And you can apply, you can advise high-risk HPV testing with or without genotyping. Okay. So this is what I wanted to highlight in this case. Apart from the first case where it was a classical LSIL, here it was, there is some noise. Somebody's not unmuted, please. Constantly I can hear some voice. Okay. Now we come to case number 7. Tanya.
Case 6.
Yes, Tanya.
Ma'am, case 6 tha mera.
I'm case 7 I'm presenting.
Acha, Mannat. Okay. But you are going to present 7, no?
Yes, ma'am. 4 and 7 were allotted to me.
Okay, okay.
A 30-year-old female with complaint of blood-stained white discharge since 6 months, itching in the perineum, and history of previous treatment for similar complaints.
So she has a white discharge, which is of long duration, but a significant finding is that it is blood stained. That should warn us why there is a blood stained white discharge. Plus she has itching in the perineum. Now itching, blood stained discharge, foul smelling discharge, these are the significant complaints, and these are generally, they have a high predictive value for intraepithelial lesions. So, and she had similar previous complaints for which she has taken treatment. Despite that, there is persistent of these features, should slightly warn you when you read such a history. Now, what are you seeing here?
And the I see fungus. In the first image, I'm seeing the shish kebab effect because the filaments and
Very
this-
correct.
it looks like a shish kebab appearance.
Wonderful. Then again here the same is magnified.
Yes.
You can see
Yes.
the filaments better. What are you seeing? This is the LBC preparation.
Ma'am, in the third and fourth, the lower fungal images, I can see in this the image that you focused, the filaments are little thinner compared to the image on the left side.
But all in all, they are all pseudo-hyphae, and you have
Yes.
both the yeast forms as well as the filamentous forms. You have the yeast, budding yeast, which will elongate and now become the pseudofilaments or pseudo-hyphae, sorry. So, which organism is this? How do you report it? Candida group of organisms, because many other organisms can resemble like these filaments. So pap smear is not a test where you can pinpoint that this is Candida albicans or any other type. So you have to broadly say that Candida group of organisms is seen in the Bethesda terminology. What is this one showing? Sorry. What is this? This I've just kept for your curiosity. This is a James Mary's stain. It is a silver stain we had done in a project where the filaments, they stand out so well in that shish kebab. So these are the fungal filaments that you're seeing, and even the budding yeast that are seen here. Here in this slide, the last one, again you're seeing this is the LBC preparation. You can see the filaments entangled, and over onto the filament, the squamous cells have been skewed up, creating a shish kebab appearance. Now, what is the classical complaint in a candidal infection? What is the
curly white discharge and itching.
So now this is not a complaint that the patient doesn't tell you that it is curdy white. That is the terminology of the gynecologist. But she does complain you of excessive discharge. And why it looks curdy? See, after putting a slide of Candida with many skewed up shish kebabs, you literally have flakes of cells onto the slide. You have thick areas and flakes on the slide, and instantly you can suspect that there will be, these are all shish kebabs, and you put it under the hyper and you start seeing this. And this is why that appearance to the clinician also, that it is curdy like. Now what are you seeing in this? Some reactive cellular changes in the form of?
See some perinuclear clearing.
Yellows. So perinuclear yellowing is also a reactive cellular change associated with a Candida group of organism. Now that halo is seen in this, here there is slight enlargement of the nucleus, which is quite striking. Yes. Here you can see perinuclear halo. This could be a metaplastic cells. You can see the fungal filaments. Here there are fungal filaments and there is slight nuclear enlargement, hyperchromasia. Is the enlargement significant? 4 times? 3 times the size of intermediate nucleus? Yes, no?
If it's 3 times, then it goes towards LSIL. Up to 2.5 to 3 times, it indicates ASC changes.
Yes, it is not more than 3 times, I feel. Or it's a borderline. It is a very subjective feeling sometimes. So if you exactly try to put in 3 such intermediate nuclei, does it cross more than 3 times? That is what you see. But definitely there is some hyperchromasia here also in some of the cells, but here the nucleomegaly is not there. There is nucleomegaly, but the nuclear membrane is still smooth. The nucleus is still smooth and round. Yes. Okay. So here you are in doubt whether to report this ATP as significant ATP or it is associated with RCCI. Here again you have a slight nuclear enlargement. Here you have again some nuclear enlargement, but there is no hyperchromasia. Is this significant nucleomegaly?
No, ma'am, it's not. Doesn't appear to be more than 3 times.
Okay. Now, there is no hyperchromasia also, but this is a LBC preparation. Now, in LBC smears, what happens to the chromasia? It's generally less.
Slightly reduced, and even the cell size can appear a little smaller.
Smaller because the cells are lying in a liquid medium. So here we have to bank more on the liquid-based preparation. You have to bank more on the size of the nucleus, nuclear contours, and the nuclear texture. We cannot, texture is becomes a little dicey, but we cannot rely on the chromasia because they appear a little hypochromatic, and texture also slightly becomes a little less visible, but still if it is significant, it is sometimes visible. So here in all these nuclei, what I want to show, there are borderline changes. Agree? You are not very sure. Some feel it is 3 times, it may be more than 3 times. The chromasia is not as much. The nuclear contours, if the size is more, the nuclear contour is still very regular, smooth, and the chromatin is not that salt and pepper. Here you can find that it is slightly coarse, but here it is, you cannot appreciate the coarseness because of the nuclear LBC preparation. So what are you going to label it as? Now again, here you have another case sort of I have added. What is this cell?
Ma'am, here there are coilocytic changes, but here it seems the enlargement, nuclear enlargement is significant.
Yes, it is unequivocal. But you have only one cell in the whole field. Here there is little dense pycnosis. Again, in this what has happened? There is binucleation.
And binucleation.
Yes, cytomegaly, but size and texture cannot be appreciated. So these are all again borderline features. Here in this, what is happening? You are seeing the
coilocytic changes, perinuclear halos, and peripheral condensation of cytoplasm.
But all of it is unequivocal or equivocal?
There's also the nuclear membrane is not seeming very regular in all of these cells, these 3 cells that are lying together.
Okay, so you would like to call this as coilocytosis.
Yes.
You want to label it as LSIL. Here we are, the cell is classical of LSIL, but it is only single. And here the morphological features qualitatively are not fitting into an LSIL. So this is what I want to show you. When the quality or the quantity of the abnormal cells are not sufficient, you are not very confident of reporting it as LSIL. Here again, what is happening in this picture? There is cytomegaly, but the nuclear enlargement is not as much. Here there is hyperchromasia, the enlargement is not as much.
Yes.
Yeah, in this, what are you seeing in the top picture where you are having binucleation?
Binucleation.
There is binucleation, hyperchromasia, but the nucleomegaly is not as much. So in this slide, there is cytomegaly, but the
and nucleomegaly is there.
Yeah, but it is not significant.
Not significant.
So what will you label this as?
Ask us to LSIL.
Yeah, so if you go step by step, would you report it as NILM?
No, ma'am.
No, despite the fact that there were fungal filaments. Now, there will be a dilemma whether this reactive cellular changes is because of the obvious Candida that you are seeing, or is it because of it is a ascus phenomena? Or would you report it LSIL because few cells you saw were very classical?
Ma'am, even if there is obvious Candida, even then I still like to follow up on this to make sure.
Yes, correctly. So you can always have a coexisting lesion of HPV infection and Candida can coexist together. They can be present in the same smear. So that's why you have to be very vigilant and keep the patient under follow-up. So you would not like to report it as LSIL nor NILM. So now we have this category, a borderline category of ASC-US, which befits these smears very aptly. So now what do you do when you get such a smear? You want to report it straight away as ASC-US, or before that you would like to do something? You see, hierarchical review is a very good thing, taking multiple opinion from your seniors, from your surrounding staff. If you have them, you're fortunate enough to be working in a department. So you can have that hierarchical multiple opinions, or you have to go into the clinical details of the patient, what all she has been going on. So we did have a history of, in this patient, she had undergone previous pap smears and she had undergone some treatment. So you have to see whether she has previous multiple NILM smears. If she has had such reports in the past, then your abnormality that you are seeing are less likely to be because of HPV infection. It is more likely to be persistent infection leading to reactive cellular changes. And then you also have to look into her reports whether you have any recent negative HPV DNA test has been done, whether it is positive or negative. And the safest is that you call her for, as you said, you follow her up and do a repeat smear after treatment of infection. So many a times, mostly all the changes, nuclear changes, which are because of reactive changes associated with inflammation, they revert back. And if they are true lesions, ASC-US or LSIL, they are persistent and you can appreciate them much better. So these are the steps that you can take before reporting ASC-US also. Now, what is this category? Can you read out quickly?
Atypical cells, ASC-US or ASC-H, the three essential features: Squamous differentiation.
It has to, of course, as the name indicates, it has to have squamous differentiation,
increased NC ratio,
yeah,
and minimal nuclear changes.
Yes. So basically this nuclear atypia must be there to call it as atypical nucleus. So definition wise, ASC-US, cellular abnormalities that qualitatively or quantitatively fall short of a diagnosis of squamous intraepithelial lesion. That is the classical definition of ASC-US. And again, to emphasize, these are the points you can read out quickly. Nuclear size?
More than 2 to 3 times. 2 to 3 times is ASC-US. LSIL is more than 3 times, and the nucleus is less than 50% of the area.
Yeah.
Hyper and hypochromasia.
Depending whether it is, yeah, you have to focus until you become used to the LBC smear, because there's always a learning curve with the LBC smears. And then you have to focus on the chromatin pattern also.
Is finely speckled or punctate or salt and peptide. And whether membrane irregularity is present or absent.
Yes, that you have to always keep a focus on. And then, as I told you, dyskeratotic, parakeratotic cells, atypical dyskeratosis, atypical parakeratosis, any two of these criteria. See here, you can see this dyskeratotic cell. It's slightly polygonal, small cells are coming from the deeper layers because of the keratinization. And these are also pleomorphic parakeratotic cells. So when 2 or more of these criteria are present, we can report it as ASC-US so that the patient gets the benefit of undergoing HPV DNA testing and colposcopy. We know that atypical parakeratosis can cover a deeper lesion or a high-grade lesion, which is a more ominous lesion. And here I've put a camelon, which camouflages itself. And similar to that, the high-grade lesion can be camouflaged by the atypical parakeratotic layer on top. So recognizing and reporting these non-classic features is therefore important. Now here,
I did want to ask one thing. Like, we did see some cells that pointed us towards LSIL.
Yeah, but if you are very confident, in this one, I believe we can go back. This one?
Yes.
Yes. So if you are very confident on a single cell, you may report it as LSI. But if you feel that no, one cell is not sufficient, although it is classical, you can put it in the borderline category. Agree? Yes, tell me the report, framing of the report.
Specimen type, we had both conventional and LBC preparations, and it was satisfactory for evaluation, adequacy, and TZ component was not seen. And
you did not see the classical columnar cells, but here and there I showed you metaplastic cells. Okay, but mentioning about the TZ component is what should come into your practice. Then general categorization.
Epithelial abnormality.
ASC-US. So we start reporting epithelial abnormalities beyond ASC-US. ASC-US, LSIL, HSIL, and more. Then?
In interpretation, epithelial cell abnormality, ASC-US favorite.
Okay, but would you like to mention about the Candida?
Yes, ma'am. The organisms that are consistent with Candida were seen.
Okay. Then in additional notes, you can give all your doubts.
Clinical follow-up and high-risk HPV testing.
High-risk HPV DNA testing. And of course, why you are asking for that? Because in ASC-US, what features you saw and which features were lacking to call it an LSIL. All that, if you want, you can make a descriptive report. Now, these are the situations where you do HPV DNA test. One, as I said, SQS, reflex or co-testing. Reflex HPV testing, or you can ask for a co-testing like we saw in that case of executive screening. Then if you have 2 consecutive unsatisfactory smears in a female more than 30 years, that also qualifies for a HPV DNA test, can be advised and should be done. And if you are having such 2 consecutive smears with NILM report, but each time the EZ endocervical cell and transformation zone component is not seen or is absent, that tells that that particular gynecologist is not consistently taking good smears from this squamocolumnar junction or the transformation zone area. So there again you can ask for a HPV testing. That becomes safe for the patient. And what are the indications of colposcopy? 2 consecutive unsatisfactory smears with clinically suspicious cervix. That is important. Clinically, it's a bad and foul-smelling discharge is there, or it bleeds on touch. The cervix is very unhealthy. Then you can, or a suspicious looking cervix, you can ask for a HPV DNA test. But the smears are not coming satisfactory. And known case of 16 and 18 positive and who's under surveillance also goes in for a colposcopic evaluation and biopsy. And positive primary screening test, HPV DNA can be used as a primary screening test, and which is becoming the norm world over currently. I think we just move a little fast. Can you read this out, please?
LSILs are not neoplasia, but simply virus-producing lesions.
Yes.
HPV and CIN1 cannot be differentiated morphologically.
So that's why it has been clubbed under LSIL. All the cytoplasmic and nuclear features will be same with CIN1 and HPV except for the koilos or the koilocytes that you see in HPV infection. But without the koilocytes also, the lesion, if it is CIN1, that's why they have clubbed it into the LSIL category. So morphologically, you cannot differentiate the 2 lesions if the koilos is absent. Okay.
Koilocyte is the morphological hallmark of HPV infection.
And it may or may not be reported in the smear. If you report LSIL, that is enough.
More than 2 non-classic criteria.
Yes, that we have seen. Atypical parakeratosis, dyskeratosis, hyperkeratosis, they have 100% specificity.
And reflex HPV DNA test in ASC-US, safety net for false negatives.
And whenever you
rate of HSIL into 18% depending on the age of the population studied.
So if the population you're studying is more than 45 years of age or 40 years of age, and you're reporting, say, 100 ASC atypical squamous cells, then around 15% of the cases will be of high-grade lesion. So that much is the importance of reporting atypical squamous cells. Of course, further categorizing into ASC-US and ASC-H is another category. But you have to be very, you have to stick to the criteria before you put that particular cell into the atypical squamous cell category, because it has these repercussions. Now, to be contained within the quality norms, you have to always, as I told you, you can review your slides by second cytotechnologist or a cytopathologist, and then only issue your reports. And you should constantly keep calculating your ASC-US and SIL ratio, and which should be around 2:3:1. So any lab should not have a ASC-US rate. It is not a waste basket entity where you put all the ATPI into the ASC-US category. So the rate of reporting ASC-US in a lab should be only between 5 to 6%, at the most 8%. And when you calculate the ratio, it should be between 2:3:1. And you have to constantly keep correlating your ASC-US cases with the HPV DNA that you have advised, what it has turned up, whether it was positive, negative, and start correlating. And that's how you keep learning more and more. And of course, you have to correlate your ASC-US cases with the colposcopically directed biopsies also to see what has come up after you got a biopsy, whether it was a low-grade lesion or a high-grade lesion, or it was just an inflammatory ATPI. So if you keep calculating all this and you be vigilant in your lab, I think your lab will be qualified for accreditation. Now we'll be very quick with the case 8 to 10. Who's for the 8? Case number, Ghazal?
Yes, ma'am. 48 years old woman with prior abnormal cytology.
So now age is also a risk factor in this woman, and there is also a report of
Prior
abnormal. Yeah, what are you seeing here?
We can see some dysplastic cells having high NC ratio and hyperchromatic nuclei. We can also see nuclear and moderate amount of cytoplasm with nuclear grooving in some.
What is the size of the cell? What is the maturity of the cell?
They are immature cells, and size is smaller than that of LSIL.
So they are less mature cells, isn't it?
Yes, ma'am.
Of the size of a parabasal cell or an immature metaplastic type of cell. Okay. So what do you think it is?
I think it is HSIL, ma'am.
High-grade lesion. Why? For 3 reasons. Because the cell type is immature.
Yes, ma'am.
L-cells you generally report in more mature cells. H-cell you report in immature cells, smaller cells, plus the nuclear abnormality, high NC ratio, nucleus occupying more than 50% of the area of the whole cytoplasm. Again, now what are you seeing in this?
Here also we can see sheets of cell having high NC ratio and scant amount of cytoplasm, scant to moderate amount of cytoplasm.
All nuclear abnormalities are there. There is molding. Here also you can see molding and isonucleosis. But this is a flat sheet. And what is this?
This looks like glandular some.
No, the cytoplasm is quite dense, more of squamous type. This is more like a syncytial cluster. Here you are getting overlapping nuclei. You cannot gauge the cytoplasm around each of the cell. Like here you have cytoplasm around each of these cells and it's a flat sheet. But the nuclear abnormalities in both are favoring a high-grade lesion. So now I have put a biopsy picture over here. These, as the epithelium becomes more and more immature, what is happening in the biopsy? What is happening to the cells? Huh? One thing, there is loss of polarity, there is overlapping of the nuclei. So that's why you start getting syncytial clusters. Each nucleus does not have a very well-defined cytoplasm around its nucleus. So there is just hypercellularity and immaturity of the cells is leading to this type of appearance. What are these cells?
These are also dysplastic cells. Having a high NC ratio, and there is some coilocytic change.
There can be. You can get in a high-grade lesion also, you can get coilocyte. So again, these are all high-grade lesion cells. High-grade lesion is pretty easily diagnosed if you know the criteria. And this is how it will look clinically. the fanning out lesions from this columnar junction. The lesion starts and it can go beyond. It's dense acetowhite. You have a mosaic pattern, and they are extensive lesions. Sometimes they are circumoral, or they can even be present only on the anterior lip or posterior lip, or they can be such satellite lesions also along with these types of lesions. So how will you report it?
Ma'am, both conventional and LBC we saw, and specimen was, ma'am, adequate for evaluation, and transformation zone component was not seen. Ma'am, in epithelial abnormalities, we'll report it as HSIL.
Yes. You want to give any description, any notes? Is HPV test indicated in such patients?
Yes, ma'am.
No. HPV test is not primarily indicated once you report HSIL. What is the next step in HSIL?
Colposcopy or excision and HPE.
Colposcopic biopsy first, directed biopsy. So if what you see in the biopsy, if you see microinvasion or not, that would be a focus. Or it's a pure high-grade squamous intraepithelial lesion, or it is coming along with some microinvasion. So there you start doing the staging of the lesion, 1A, 1B, and depending on the depth of invasion. And depending on that, you decide whether you're going to do a loop excision or that leads type of excision, or you'll do a cone biopsy to see whether there are more such areas of HSIL with microinvasion or not. So the biopsy that you take, the punch biopsies that you take, colposcopically directed, will decide many things. In that biopsy, if you do not get microinvasion, but colposcopically the lesion is very large, circumoral, as I said, you will have to go in for a cone biopsy to see more areas of microinvasion to decide the staging of the lesion. Okay?
Yes,
So
ma'am.
all that you will have to put in your additional notes. Of course, we are talking about a colposcopically directed biopsy. Now, case 9.
In case 9, 32-year female routine screening, cervix was unhealthy.
So what do you understand by unhealthy cervix, just for the sake of repetition?
Ma'am, any discharge or
Discharge is present or not?
bleeding?
Bleeds on touch or not? Discharge, whether it is foul smelling or not?
Yes.
Whether the cervix is hypertrophic? Whether it is seen completely or not. Sometimes it is flushed with the vagina. You cannot see the anterior lip. Sometimes you cannot see the posterior lip. That all indicates whenever there is malignancy, the cervix gets pulled up, and then this is how would be the appearance of the unhealthy cervix. Now, what are you seeing here?
Ma'am, here, ma'am, there is nucleomegaly.
First on the cytoplasm. First on the cell size.
Cytoplasm, metaplastic cells. Then
It's abundant. Cytoplasm is abundant.
Yes,
so is it a mature cell or immature cell?
Mature cell.
It is a slightly more mature cell. Now,
Yes.
a mature cell having this bigger nucleus. So is it a cell of LSIL?
Ma'am, it's more than, the nuclear size is more than 3 times that of an intermediate, so ma'am, LSIL.
So this is a LSIL cell. This one particularly is a LSIL, and you are calling it metaplastic because the cytoplasm is dense. So this we can call it as ASC-US in metaplastic cells if the number of cells are less, but this one is a classical one. Now here again you are getting all these metaplastic cells, same morphology, dense cytoplasm, hyperchromasia, enlarged nucleus, and here you can see binucleation, membrane irregularity. So this is another situation when you can get ASC-US not only in mature cells but also in immature cells. Now, why will you not report this as HSIL? Because they are seen in parabasal cells.
Remember, nucleus is less than 50% of the
But basically, we have to focus on the quality of the cytoplasm. Cytoplasm is dense. So it could be
Dense.
an immature metaplastic cell or it could be a parabasal cell.
Yes, ma'am.
So you would not like to put it as HSIL?
No.
So the dilemma is very clear. The way you're mumming, you're very correct. Your doubt is absolutely fine. There is maturity of the cytoplasm, there is enlargement, but again, it is not qualifying for all the features of HSIL. Like we
Yes,
saw the cells of HSIL where you have a very high NC ratio, and
yes, ma'am.
now these could be cells of CIN2, but we are
CI.
not segregating CIN2 and CIN3 on the basis of pap smears. That was the purpose of the Bethesda system, and it created the two-tiered morphological classification. To you, this may be a cell of CIN2. To me, this could be CIN1. Someone else may call this as HSIL cell. So others may call it differently. So CIN2, splitting CIN2 and CIN3 is not done with the Bethesda classification. So you keep it, and you can still be keep your case on the borderline category and then give the patient the benefit of further workup.
Yes, ma'am.
Now, what are you seeing here again in this?
Ma'am, here
Metaplastic
clusters,
cells.
metaplastic
What I'm
cells.
trying to show you is nuclear abnormalities in metaplastic cells, what all you can get, right from ASC-US to LSIL type abnormality and high-grade type of lesion.
Yes,
Now tell me.
ma'am, these
This
are, there's some parakeratosis also there present, ma'am.
where you saw this you're calling it parakeratosis.
Ma'am, जो बीच में the color in the middle of the cluster.
Now, these are more of metaplastic cells, polygonal cells, angulated cytoplasm, dense. It
Yes.
looks like a more, they have these pointed ends, high NC ratio, atypical nucleus. Here you have all these parabasal cells. Again,
Yes.
this is also a metaplastic sheet which has pulled out nuclei appearing very spindly. Now, these are again cells. Now, we are coming to another borderline category where you are not very sure whether this is high-grade lesion
Grade
or you want to call it a
SH.
low-grade lesion, ASC-H. Okay.
Yes.
So here you have these cells.
Yes, ma'am.
What would you like to keep them?
Ma'am,
Now you
in
have,
SH, because the quantity of atypical cells are less.
okay. So does this cell qualify for ASC-H?
Yes, ma'am. It's high NC ratio, hyperchromatic nuclei.
It's a small cell, high NC ratio, but you're unable to see the chromatin texture. Here again, this is a very dark looking cell. And this happens with LBC patient very commonly. You do get some, because the cells are hanging on in the fluid for a long time, they become rounded up. And when they are put onto the slide, you are unable to differentiate the cytoplasmic rim from the rim of the nucleus. They just appear like these dark blotches. And it's sometimes really very difficult to label it as a high-grade lesion or to just ignore them as rounded atypical metaplastic cells. So that is the category where that is the time when you can use the category of ASC-H, or if you are very confident and you see some more unequivocal cells, you can put it as high-grade lesion.
Yes.
So yeah, this was, again, I will come to those questions. Would you report it as NILM or just a reactive cellular changes? With
No,
all
ma'am.
these, no, you cannot leave it like that. Should you report
No.
it as HSIL?
Ma'am, quantity of cell were less, so I would
Yes,
not.
quantity as you said, and of course the quality. Here I am unable
Quality,
to
yes, ma'am.
gauge the NC ratio exactly, or whether it is artifact, right? Starting from that end, you are confused. But other cells are showing some abnormalities. Like here, mature cell is showing abnormality. So you can always have a low-grade lesion coexisting with a high-grade lesion. Here you are seeing an abnormal cell, but this cell is not very clear to you, or this cell is very dark, you cannot differentiate. So you can have coexisting lesions. So you cannot put it as high grade. So if you use the category of ASC-H,
yes,
yeah, that comes to your rescue. Here again in these are all immature metaplastic cells. Each of the cell has a very nice cytoplasmic margin. NC ratio is high, but somewhere the stratification is maintained. So these could be immature metaplastic cells coming as a result of repair. But again,
yes,
here you're seeing a keratinized cell over here. So
yes,
this
ma'am.
keratotic cell. So you are not very sure that whether these are RCCI associated with repair or it is actually ASC-H, a high-grade lesion. So in that case, you can put it as ASC-H. What is the next step of ASC-H? The patient undergoes colposcopy. There is no HPV testing. The patient has to undergo colposcopy. See here again, I wanted to show, and this is a very common thing that happens. This is a large cell, but somehow it's very, this here you don't even see a rim of cytoplasm here, but you are not seeing the texture of the nucleus. Membrane is not irregular as it is irregular in this one. You have these notches, and then you have coarse chromatin, blotches of coarse chromatin. So all these dilemmas, and if you have these abnormal cells, which are very few in the smear, you have these abnormal cells and you have these dyskeratotic cells along with it, and there are very few hiding here and there. We sometimes call them as litigation cells. So these are reactive cellular changes of inflammation and repair, which can be confused with high-grade abnormalities, and therefore you can put it as. Now see, this is a metaplastic cell where having a two-tone cytoplasm, high NC ratio. Do you want to put it as HSIL or just exuberant repair, coarse chromatin over here? But there are a lot of inflammatory cells entangled. You are not very sure. An isonucleus is there, but it is a flat sheet of cells. And nucleoli are there. So in repair, you keep getting nucleoli. Yeah, so that favors a reparative phenomena rather than a high-grade lesion. So when you are in doubt, you can put it as ASC-H. So there are differential diagnoses of ASC-H. Cannot rule out high-grade lesion. How will you report this?
From specimen type, we had both conventional and liquid-based cytology. Specimen adequacy was adequate for evaluation, and TZ zone
was seen. We did see metaplastics.
So yes, ma'am.
Yeah. Then
in general categorization, epithelial abnormality, ASC-H.
Yes, if you are sure it is a HSIL, that you will put, or if you want to put ASC-H, you will put it like.
Okay.
Then you write all the comments and advice. What will you advise?
Colposcopy.
They know that, but from our side, we can also always advise colposcopy. The patient does not HSIL and ASC-H. The next step is colposcopy. For ASC-US and LSIL, it is HPV. And in LSIL, always not if the patient is less than 30 years of age. Now, this is something like hyperchromatic crowded groups, where you cannot see the quality of the cells because of the dense clusters. So these also qualify for a ASC-H category.
Yes.
Again, you have these hyperchromatic crowded groups. I'll just move a little fast, and they are for ASC-H category. Then in this category, you also can take the help of the surrogate marker. Immunocytochemistry can be done, where P16 is very effective, and it can be a triage in cervical cytology test. This is a whole field by itself. And even on cell block of LBC vials, you can do P16 and Ki67, the dual stain, which where the Ki67 takes a red coloration, and whereas P16 stains both the nucleus and the cytoplasm. And if both the stains are positive, when you were doubt about ASC-US, that lesion directly turns into a significant lesion, and surveillance of such patients, colposcopy and biopsy becomes very important. Now, this is something you have to remember. The ASC category, atypical squamous cells, is one category, the borderline category. When you are having this category, 80 to 90% will be of go into the category of ASC-US. So just remember that in any lab, the ASC-US is the most common cytological interpretation which is going out. That's why you have to be very vigilant and keep it curtailed within the range of 5 to 8%. And what is the follow-up in such patients? You read it out, Ajit?
Repeat cytology 6 and 12 months and reflex HPV test.
You can do reflex immediately if there is affordability, or you can ask the patient to come at 6 and 12 months. If the abnormalities are persistent, again, you have to do the reflex HPV testing becomes mandatory at that point. Now, out of all the ASC cases, atypical squamous cells, 10% will belong to the ASC H category. The next step will be
Colposcopy.
And you can the ASC category keeps on declining with the increasing age of the patient. So all the lesions become significant in the ASC category between the age of 30 to 50 years. But with as the age increases, the atypical category also reduces. Now this is something very simple for all of us to diagnose. Case 10. Rachna, boliye.
Yes, ma'am. 55 years old female complaining of postcoital bleeding, burst speculum findings, anterior lip of cervix flush with vagina, and pervaginal findings, cervix feels hard. Clinical history is more inclining towards carcinoma, malignancy. And ma'am, smears show scanty cellularity, but cells are showing high NC ratio. Cells are arranged in
I can see large clusters and there's so much cells, so many cells I'm showing you. Okay, the cellularity is adequate.
The cells are arranged in syncytial pattern, and few cells show
You tell me what you're seeing exactly here. You have written a description, that's good. But what exactly in this, where my pointer is, what are you seeing here? What is the morphology like? Syncytial cluster of cells.
syncytial clusters.
Are you able
Overlapping
to
of nucleus.
identify what is the nature of the cell? Superficial, parabasal, intermediate? Are you able to recognize? Yes.
Ma'am, parabasal
Yes or no?
cells.
Yes or no?
Parabasal cells.
Gauge the you cannot gauge the maturity of the cells. It's a syncytium. Syncytium means multiple nuclei in a common cytoplasmic background. And at places वो तो background भी नहीं दिख रहा है यहाँ पे. Okay, somewhere it is seen, at places it's not seen. Then what else you are seeing? Hyperchromasia.
Yes, ma'am, hyperchromatic. And bizarre cells showing bizarre nucleus, high NC ratio are also seen.
And yeah, are you seeing some nucleoli? I have focused it here.
Yes, ma'am. Few cells are showing prominent nucleoli and
what does that signify? What does that signify?
Ma'am, as we go deeper, the nucleolar size becomes more prominent, depending upon the depth of invasion.
Presence of nucleoli signifies invasion. So
Yes.
probably there is a micro-invasive lesion or a frankly invasive lesion. Now this cell is a very different cell. Here there is cytoplasm. Here you would not think this was a syncytium. Here there are individual cells with abundant cytoplasm. And how would you describe this nucleus as?
Ma'am, it is pushed to periphery and hyperchromatic nuclei.
Dense hyperchromatic smudged cone-like, which is a typical feature of squamous cell carcinoma. Here I want to demonstrate what is tumor diathesis. You told me clinically only you were very sure she's having a carcinoma cervix. So what are you seeing here?
Ma'am, tumor diathesis includes necrotic debris or keratic debris.
That necrotic material will be proteinaceous material plus keratin. Granular keratin. See in this
yes,
picture, you are seeing many malignant cells. What are the three different types of cells you see in squamous carcinoma?
Ma'am, tadpole type of cells, fiber cells, and
type 3 cells, which are round cells, like this one you're getting here, this one. Okay, very round cells. And you have these cells with tails of cytoplasm. Here you have seen the fiber type of cells. Now this is the LBC preparation. This is a conventional preparation. So for tumor diathesis, I want you all to be very clear what are the components of a tumor diathesis. Necrotic material, which means proteinaceous material coming from the cell lysis, cytoplasmic lysis. Then you have the keratin, which gives that all that necrosis a pink color, orange color. Then you have old blood, which is very important. And you have plenty of acute inflammatory cells. Now, what is the difference between tumor diathesis seen in LBC smear and a conventional smear? What do you call the diathesis in a LBC smear? Clinging type of diathesis. Now, because you are vortexing the vial, the cells are undergoing gradient sedimentation. So all the necrosis, the muck, the mucin, everything is held up into the upper layers. And a clean cell button goes down. But what happens in carcinoma cervix, because there is excessive necrosis, some amount of necrosis still keeps clinging to the cells and it goes into the cell button. And then it is also reflected in the smear, and that is what is called as clinging diathesis. So the generalized background of the smear may not be necrotic, but clinging to the cells you will have some necrotic material, and which is little difficult to recognize, and you have to train your eye to see clinging diathesis as against a conventional smear where it is very easy to see this granular material all over in the background of the smear. And here you will see like this type of clinging diathesis. Is it clear? I have just
Yes, ma'am.
made it clear, not waited for you to answer those questions. So how will you report this?
Specimen type, both conventional as well as LBC.
Yes.
Specimen adequacy, ma'am, TZ component was not identified. General categorization, it is positive for squamous cell carcinoma. Most
Now
probably.
suppose you did not get adequate number of cells. What happens is when the growth is quite significant and there is so much necrosis on the surface, you get the number of cells required to call it adequacy is not important. I mean, it's very is not meeting. You're not getting those 5,000 and 8,000 cells. But you are seeing all these abnormal features. So still you will report it as squamous carcinoma?
Yes, ma'am. We will report it as squamous cell carcinoma.
So it still becomes adequate smear if any abnormality is present.
Right.
Okay. Now what will you write in your additional note? And would you like to write anything? A descriptive diagnosis of the types of cells that you saw.
Cells showing high NC ratio, tadpole cells are seen, fiber-like cells are also seen, and tumor diathesis present in the background.
Yes, that is very important. That is, even if you have written squamous carcinoma, description of the tumor diathesis is very important, because that brings on record that actually necrosis, you are very confident about the necrosis. So as we are detecting more and more precancerous lesions, sometimes there is a dilemma between HSIL and because the cells of HSIL are similar to the cells of squamous cell carcinoma many a times. So what is missing is only the necrosis in the background. So if you are very sure there is no necrosis, you will put it as HSIL. But if you are sure that there is necrosis, it will go into the category of invasive malignancy. So that putting that in your notes or comments is important for the documentation purpose. Okay, anything you want to ask? Any questions?
Yes, ma'am. Thank you so much. Was a wonderful session. I'm sure the residents have equally enjoyed it as much as I have. Ma'am, there are a few questions in the chat box. Would you like to take them, ma'am?
Yeah, no problem. I can.
Yes, ma'am. So the first one was, how really do we count 5,000 cells for adequacy?
Yes. Now that you have to see, generally with practice you come to know, but for LBC smears, you have to count the cells under a high power field. And you have to start choosing areas both at the periphery and in the center. So generally they say that you start from the center and go to the periphery so that you are not missing out. And like this, you count 50 fields. Agree? And then multiply the cells.
Yes, ma'am. Thank you. Do we need to mention cytohormonal score as part of the reporting by Bethesda System?
Bethesda System really doesn't, it doesn't really do hormonal assessment or the scoring thing. These days they are really not doing, and they are saying that the purpose of the pap smear is to detect CILs and malignancy. So it's no longer used actually, but still at the same time there is a lot of literature being available in all the textbooks regarding the hormonal evaluation, because sometimes an odd gynecologist is coming up with the old timers maybe there, so they want to know what is the hormonal status. So for our knowledge sake and sometimes to apply it, we should know all these things.
Yes, ma'am. The next question is, can lactobacillus and trichomonas coexist?
Yeah, they can. They both grow in an acidic environment. They
Okay,
can
ma'am.
grow in acidic environment,
one
but
of the-
Candida grows in an alkaline environment.
One of the residents have asked, what is meatball here? I think he's referring to the spaghetti and meatball appearance.
Sorry, Noshin, I got a call. So, I want to know what is a meatball appearance?
Yes, ma'am.
Yeah, so we talked about those TV bodies along with the leptothrix. So the leptothrix, they resemble the noodles, they are saying, and they are very delicate, long structures in a coiled up manner, appearing as a hairball or like noodles, and those bodies, the round bodies of TV, are like meatballs. So that's just a name given simulating some material.
Yes, ma'am. Someone has asked, can candidiasis also show halos, ma'am?
Yes, yes, of course. One of the reactive cellular changes, most significant changes, is perinuclear halos. That's why I showed the case of where you had a lot of Candida halos, plus you had the epithelial lesion in that.
Thank you. Next question is, in intermediate cells, will you term it parakeratosis or dyskeratosis?
See, here you cannot, when you're calling it parakeratosis, it's slightly a compression of the mature cells together. Although we say they are superficial cells which are dense, compact, contracted with dense cytoplasm, I think it takes into account the intermediate cells also. So you cannot separate the parakeratosis into intermediate or superficial type. It's just appearance of small miniature keratinized mature cells that have more cytoplasm as compared to the dyskeratotic polygonal cells.
Someone has asked, what are the non-classic changes?
I have depicted a whole slide, no, in that. You have this hyperkeratosis, you have keratin cakes in that. You get keratin cakes or you get plenty of anucleate spams spread all over the slide. Then you get this parakeratosis, atypical and dyskeratosis, and partial chondrocytes, rafts and pearls. These are the features.
Yes, ma'am. Thank you. And there's one last question. Can we see true septate branching in vaginal smears? Hyphae.
True septate.
I am not able to understand. Do we see true septate branching hyphae in vaginal smears?
And I haven't seen in all my career like getting aspergillus or any other infection that has true septate. I haven't seen that. So generally Candida and its other morphological forms are there. Pseudohyphaes are more common.
Yes, ma'am. Thank you so much. I think that is all for today.